Good morning, Dr. Himakshi.
Good morning, ma'am.
Join. Join. Himakshi, tell me whether my screen is back, ulta or sidha.
It is ulta. It is turned. Yeah.
It's ulta. Na?
Hi, Nadira, ma'am. How are you?
I'm fine. How are you? I always get
I'm
it.
good.
Okay, then let me not take that. I'll just change it back. Let me see. I'm going to do one more experiment. Okay, mirroring. All right, I'm going to remove the mirror. Now also it's
Still
ulta.
the same. Still the same.
Just let it become blurred. All right. Okay. Blurred. Hello, Ankita.
Good morning, ma'am. How are you?
Good. Good morning. Good morning. Lots of work, lots of preparation.
Yes.
Preparation always.
Hello, sir. Good morning.
Good morning.
So we'll start in just 1 and 2 minutes.
Take your time. Let people usually take 5 minutes more.
Yeah.
So we give them that till we have an informal hello. So it's
Hi,
fine.
Ankita.
Hello. Hi, Nidhi.
Hi.
So how punctual are you? How punctual do you want me to be?
Ankita, I think she has question for you.
Sorry, I was outside. Yeah. Tell me, ma'am.
How punctual do you want me to be?
It depends now about your topic. And
Bad question.
if you want to listen your expertise, so you take time and give us the best things.
No. No expertise. It's just me as a patient, nothing else. Nothing.
So let's just wait.
So will you give me the screen sharing? You can
Yes,
close
ma'am.
it.
I'll give you when I announce your name. I'll give you. I'll make you the host.
I think Varsha will also need it. I'll try, but if I fail, then she'll try.
Okay. No problem.
Good morning, Dr. Sarbadikari. Good morning, Dr. Odgon. What do we call you? Your name is a little tongue twister for me.
Good morning. Can call me Suptan. No problem.
No. We'll learn. Good morning, Dr. Sharad.
Good morning, ma'am. Good morning. Very good morning.
And Dr. Odgon, how do you pronounce your first name?
Or Sesame, no problem. Whatever.
What are you called? Normally, what are you called?
Sesame, okay, no problem.
Jism. No, say it again. I want to learn it.
Jism.
Jism.
Yes,
Okay.
that's right.
Okay, that's right. That's Jism. That's good.
Hello.
Good morning. It's always nice to see from different places. And I think COVID gave us this gift of reaching everywhere while sitting at home.
Yes.
You know? So none of you all can see that I'm wearing home slippers. You can only see my yellow sari. That's the beauty of a Zoom call. But it's okay. At least we can reach, at least we can meet. It's great. Great to see new names, great to see new people. It's always a pleasure.
So I think we can start, ma'am, with your permission,
Up to you,
because
up
I
to
think
you.
people will join in between as well.
Certainly. It's over to
Okay.
you. You want to wait 5 minutes more? You can, because I think you've got that admit thing there, no? So people are
Yes,
in
yes.
the queue. Some people are still in the waiting room. I can see 3 people in the waiting room. Yeah. So
Yeah,
maybe,
we are doing the same time. My team is doing it.
right? Yeah. Another 2 minutes, perhaps 11:05 we can start.
Okay.
You-
Okay, no
5 minutes.
problem. We can do that one. We can do
Just
that.
helps out. How many have you sent the invite to, Ankita? All your associates, all your accredited institutions?
Yes, ma'am. You have shared it everywhere.
I think it's such a season. Everybody's occupied with something or the other, right?
Yes, ma'am. Today is the day most of the people are in the
Yeah.
conclave and most of the people are at different places
Lots
as
of
well.
places. Yes. Sunday was
Yes.
also busy. I think Sunday also because it was the Sunday before. And I think
Yes.
it's allowed, which is fine, yeah.
So I think we should start. It's 11:05 and
Absolutely,
not taking much time. Thank you, ma'am, for your permission.
Absolutely.
So, good morning, everyone. It's an absolute honor to welcome you all to this important occasion on World Patient Safety Day 2024. And there is no greater responsibility in healthcare than ensuring the safety and well-being of our patients. For every diagnosis, every treatment plan, and every medical decisions, we are reminded that lives depend on getting it right. So today, as we gather to celebrate patient safety, we reflect on the theme set by the World Health Organization for 2024, which is improving diagnosis for patient safety. Get it right, make it safe. This theme emphasizes something fundamental. A correct and timely diagnosis is not just the beginning of the journey to recovery. It is the cornerstone upon which patient safety is built. In healthcare, even a single misstep in diagnosis can lead to profound consequences. We all share a duty to ensure that every patient is treated with the highest standard of care, precision, and compassion. Today, we will explore how timely, accurate diagnosis can transform patient outcomes and contribute to safer healthcare practices around the world. Before we begin, I would like to extend a heartfelt welcome to our esteemed speakers and panelists for today's session. We are privileged to have experts from various fields who will share their valuable insights on improving patient safety through accurate diagnosis. So I would like to welcome our all speakers. I would name them and then let you know about them because it's very vast. They are experts from every industries. So I would like to welcome our ma'am, Ms. Nadira Chaturvedi, Dr. Zisim, Dr. Himshika, Dr. Indu Harneja, Professor Suptan, Dr. Sameer Syed, Dr. Sumesh, Dr. Sharad, Dr. Kumar Velu, and Miss Nidhi as well. They will be speaking a lot of experience from their organizations and the expertise they have. So we will be very honored to listen them and we'll get the knowledge so that we can also practice the same thing in our hospitals or our areas of work. So before going forward, as per the program schedule, I will be going forward with the first and the foremost thing, which is introduction to the QA. I hope everyone can see my slides.
Yeah.
Okay. So introduction to the QAI. I am Ankita B. Gill for you all again. I am an Assistant General Manager in QAI and working with my team for the Center for Accreditation of Health and Social Care. So QAI introduction, we are the accreditation body of which operations has been started in August 2017 and we are the fastest developing accreditation body in the world. Why we are the fastest? Because we have developed number of accreditation standards in these 7 years, which is around 17. So we have different standards like if you talk about hospitals, small hospitals, we do have dialysis, stroke, and there are many other accreditation programs which we do have for the different industries. So in the QAI, we have different boards. The first board is Center for Education and Training, CET, which talks about the awareness, webinars, sensitizations, assessor programs. It takes care of all these things to make you enhance your skill development. Center for Accreditation of Health and Social Care, right, where we provide the accreditation and certifications to the hospitals and healthcare providers. Center for International Accreditation, which was previously it was Center for Laboratory Accreditation, so I will tell you brief about it, and Center for Veterinary Facilities. Our programs. So first, Center for International Accreditation, which is chaired by Professor Vikram Kumar, former director of CSIR National Physical Laboratory. So we do have a lot of programs in this. Yeah, sorry. So we do have a lot of programs in this accreditation of medical laboratories as per ISO 15189, which is a medical laboratory requirement for quality and competence. We do have accreditation of testing laboratories as per ISO IEC 17025, general requirements for the competence of testing and calibration laboratories. We also do have certification of medical laboratories as per the requirements of the Central Clinical Establishment Act. And also we are looking for accreditation of calibration laboratories as per ISO IEC 17025, general requirements for the competence of testing and calibration laboratories. Also, we do have in the same biobanking accreditation, which is one of our first time in India, which we have launched by the QAI, is ISO 20387, general requirements for biobanking. We have accreditation of inspection bodies as per ISO IEC 17020, which takes care of conformity assessments, requirement for the operation of various types of bodies performing inspections. Accreditation of proficiency testing providers as per ISO IEC 17043, which talks about conformity assessments and in proficiency testing. Also, we have accreditation of reference material producers as per ISO 17034, general requirement for the competence of reference material products. So when we talk about the CIA accreditation program, we have medical lab, testing labs, calibration labs, and the biobanks, which I have already talked about it. And in the testing lab, we have the highest number of 76, and also we are looking after the other labs. If you talk about number of accreditations in the previous years, we have crossed good numbers and we are hoping for the most other numbers as well in the future. And you can see in 2024, we have 47 and the trend is going very good in this case. Now, if we talk about Center for Accreditation of Health and Social Care, which is board chair is Professor M.C. Mishra, who's a former director in AIIMS, New Delhi. So as I've told you, we have a lot of programs to provide you accreditation and certification. So we have clinics, we have ambulatory care facility, the hospitals, home health care, transition, inpatient rehabilitation, telehealth, portal and home stays, dialysis centers, ART, IVF, emergency department, green healthcare facility, patient safety, WHO patient safety friendly hospitals, primary and advanced stroke centers, vision centers, and QAI 7101 plus. And recently, we have launched medical transport organizations for the ambulance services, emergency medical services, who are providing all over India. So we are providing all the accreditation program for that. And also work in progress is bone marrow transplant and hair transplant clinic. So you will be soon getting notifications about these other standards which we are going to launch in future. So we are waiting and hoping to get it launched soon. So number of accreditation in the previous years under CAHSC is we have started with 1, but the number has increased to 115, and we are very happy with our clients that they are also happy receiving the accreditation and certifications. And we are hoping to increase this number next year also. And of course, we need all our clients, previous and the new one, to be having trust in us, and we'll do the best together. Number of healthcare accreditation in the previous years, we are very good and leading the ART IVF by 54 numbers which are accredited. Home healthcare, we have already 7. Dialysis, we are in 8, and WHO 1, ambulatory care 5, and then telehealth 2, emergency department 8, transition care 4, stroke centers are 17, hospital 6, certification of hospitals 1, clinics 1, vision 1. So we are going to increase this number, and we have a lot of applicants in line, and soon you will be watching us in the next slides with the highest numbers. International recognitions, so we are definitely have some international accreditations so that it develop the trust with the clients. So QAI is the first accreditation body in India to achieve ISQA EEE accreditation in less than 5 years of operation. So it is one of the tedious tasks to get these kind of accreditations. So we have received that ISQA EEA. Also, one of the good things for the hospitals and other centers that QAI accreditation is recognized by the Ministry of Health, CGHS, for empanelment of private hospitals, eye centers, dental centers, and imaging centers. So most of the hospitals who are applying, we are already paneled with the CGHS, and you will also get the panels for the same. QAI CIA is a full member MRA signatory of the Asia Pacific Accreditation Cooperation, APAC. We have received those certificates for the medical testing ISO 15189, and we're testing ISO IEC 17025. Also, QAI is a CIA is a full member MRA signatory of the Internal Laboratory Accreditation Corporation. So testing ISO 15189 and testing ISO IEC 17025. So this is our gold accreditation mark, and whosoever gets accredited, they can use this kind of mark for their promotional and other activities also on their websites. So all the applicants and other clients could always get these accreditation mark while applying those accreditation standards in their hospitals. So our clients, I would like to read few of them. Like you can see, ART and IVF, we have the big players also with us. So these are our clients who are in the different programs. They are home health care. We have other different clients who are very big and pioneer in the healthcare. For the dialysis centers, we have for WHO patient safety friendly hospital. This is our accredited hospital. Emergency departments, ambulatory care facilities, hospitals, small hospitals, and certifications. So these are all the hospitals which have got the accreditation, and also they have got the empanelments for the CGHS. Telehealth facilities, transition care centers, the advanced stroke centers again, advanced stroke centers. So these are all the clients who are already accredited. Primary stroke centers, the clinics, the vision centers, other vision centers who are with us from the long time, and they have developed the trust in us. Vision centers, QAI 7101 plus. So these are the basically our clients, which we have. Of course, the slides will be more, but we have shown you everything which we have, right? So geographical spread. So we have our services all over globally. Basically, we have also in Nepal, Mongolia, Myanmar, Bangladesh, Maldives, South Africa, UAE, Bahrain, Qatar, Ghana. And we are working in the progress, and we are doing some other tie-ups with other countries as well, which includes Gabon, Morocco, Congo, Oman, Kuwait, Uzbekistan, Kazakhstan, Georgia, and Canada. So soon you will be finding more of the slides of the clients with those countries as well. So announcement updates. I would like to take this platform and inform everyone that we are always active on social media and LinkedIn. So anything related to any webinar, sensitization, dive programs, SSL programs, everything you will find on LinkedIn. So try to be active on LinkedIn with us, follow us so that you can see most of the things which are happening in QAI and what could benefit you, because we are doing under awareness programs, we are doing a lot of skill enhancement programs. Those could be the trainings which you can take and develop your skills and become an assessor with us. Maybe you can be an empanelment one day and become an assessor and go for the other programs as well. Also, we have a website for all updated related trainings, programs, and new announcements. So you can check our website, right? All the links are present everywhere. And you can see the website for recent announcements. So I'm sure that if you have any questions, you can reach out to me. My email ID is ankita@qai.org.in. And most of you have my email ID, and I'm also our website. You can also reach to us www.qai.org.in, info@qai.org.in. Our contact details are also displayed everywhere. So please reach out to us for your all queries, and we are really happy to help. My team is very dedicated to take this quality and accreditation services at every corner of countries. Thank you so much. Now, doing the continuation of this program, I would like to invite our first speaker of the day, Ms. Nadira Chaturvedi. She is a management consultant and academician and social entrepreneur and a co-chair for Patient Safety Foundation India. And her expertise in patient safety is one of the things which is vast. So we are expecting a lot from her. And to welcome this session, I would request ma'am to please tell us whatever you have so that we will be enlightened with your words. Thank you so much. Please continue. Over to you, ma'am.
Ankita. Thank you. Thank you. First of all, good morning to all the participants. It's almost, it's not yet an afternoon. And that was a brilliant introduction to QAI. I'm so impressed each time I hear it. And I really wish you the best to grow wider, broader, and deeper into all the aspects of healthcare, not just the hospitals. I think that was lovely. Thank you. And thank you for giving us this forum to introduce the work that we do. I was given two tasks. One was defining or a little, a bit of expansion on the title of the WHO theme, Get It Right, Make It Safe. And the second is telling you what we are doing about it as a Patient Safety Foundation. Now, first of all, my best wishes and respects to all the doctors, diagnostic experts, and clinicians and facilities that have taken accreditation here. All of you are doing a tremendous job. So if I say anything, please do not take affront to it. I'm giving you a perspective, not as a doctor, but as a patient, as a caregiver, as a mother, as a daughter, as a sister, as a daughter-in-law, as a human being, as we are, all of us here. In some form or the other, each of us is a patient, each of us is a caregiver or will be a caregiver. And we are Indians, we will always love our families and we'll go beyond what we can do to help our families. That's the hat I'm wearing, and that's what I'll bring it. So before Varsha begins to share the presentation, I just want to define, there were two aspects in this statement: diagnostic safety, get it right, make it safe. I'll dwell first on the get it right. Varsha, please put on that and start the presentation as I talk, the first two slides. So I think diagnosis is the beginning of the whole journey. Everybody knows that. And a wrong diagnosis is as simple as wrong treatment. I mean, to put it very, very simply. But there is a stage that goes even beyond that, before that, not just during that. Everywhere I hear, even 2 days ago, there was a brilliant webinar by Kaho, and all the people spoke excellently, expertly, but the geography remained hospital. The geography remained after the patient came in, before the patient left. What about the places that comes before? And what about the space that comes after? To me, as a person, that is my most important thing. But I'll come to that later. So getting it right as diagnosis itself, next, is dependent on what input you get. I'm going to park that statement. I'll come back to that statement. But since that half of the statement comes first, to us as human beings, to us as patients, it means misdiagnosis. It means delayed diagnosis. To me, they're the same and as bad as wrong diagnosis. I'll give an example. I have a friend who had diarrhea, constipation, 2 years, not 1 month, not 2 months, not one episode, not 2 episodes, 2 years. And they went to the doctor. The gastro person gave medicines. They changed the diet. They changed the water. They changed the country to get clean air and clean food. They even went to America. But the malaise did not leave them. Until finally, the pain was so bad, the constipation was so bad, they had to go to another hospital and they discovered that it was colon cancer at an advanced stage, ending up in it was surgical procedure, and they will have a colonoscopy bag for the rest of his life. Now, what went wrong? Who went wrong? Was it misdiagnosis? Yes. Was it delayed diagnosis? Yes. Was it wrong diagnosis or diagnosis too late? So these errors, when the patient comes and speaks and tells you, and still it is missed, is part of that program. But sometimes it can also happen that we do not report errors. I'll give another case. My cousin, my husband's cousin, in the middle of the night, he had heartburn, young, maybe late 40s. He gets up, he tells his wife, I'm having heartburn. She says, just take a Gelusil, go back to sleep. At 2 o'clock in the night, nobody's going to help you. You overate. He opens his laptop, and we discover that the next morning. And well, he takes his Gelusil, he goes to sleep, and he never wakes up. Now, his daughter, he always woke up his daughter in the morning before going to school. And when Shreya went to him and said, Papa, why haven't you woken me up today? She found him cold, lying on the floor, absolutely stone cold. She went to his laptop. The screen was open. The heartburn page was open. The symptoms were the same as indigestion, but actually it was a cardiac arrest. So we missed the signs. There was nobody to tell us the signs. He did not know. He did not come to the doctors. So how can we blame the doctor for diagnosis? So errors happen before we come to you. Errors happen after we come to you. And there are many reasons, but the resultant is the same. I'll pick up the fourth item here, technical errors. I remember I'm a cancer survivor. I had to take, every 3 months I was taking tests. And one day I was close to my 2 years period. I was very happy. My hair had grown back. I remember that clearly. That's why I remember the 2 years part. And the report said, it was an ultrasound. The report said recurrence. You know, we are mortally afraid of recurrence for anything, whether it's HIV or AIDS or TB or anything like that. Of course, cancer always. And I called up my oncologist. I said my bye-byes to my children, my son, my daughter. My husband was with me. We were going to a wedding. I called up my oncologist in the car. I remember we were all dressed up for a wedding. We did not want to cancel that. And my doctor said, impossible. He did not look at the report. He said, it's a technical error. Can you believe the expertise of that man? He did not subject me to unnecessary chemotherapy or radiotherapy. There was no radiotherapy for ovarian cancer anyway. And he said, no, it's not possible because I know your pathology. I know the way you're growing. I know the way you're prospering. So technical errors do creep in. It is something more than just technical. Diagnosis is more than diagnostics. We cannot get just, I heard day before, 70% of treatment decisions are based on diagnostic tests. Oh my God, which means 70% can go wrong. That is the corollary that I picked up. I didn't want to say it there, but I'm saying it today. If you're basing your 60-70% decision-making on a particular test, which comes out from a machine, and the expertise of the skilled technician is all you depend on, something is wrong. But the answer came on the same day. It was the last item, the communication. And communication between the doctor and the diagnostic expert. We were always bothered about communication with patients. No, I learned 2 days ago, and that was brilliant. Whenever I come to these gatherings, I always go back wiser and more learning. And thank you, all of you, for giving us those inputs. So if the doctor tells the diagnostic person, Is it for preliminary screening? Is it for reconfirming a diagnosis? Or is it for just investigation? Or is it just a preventive health checkup? I think the slant, the orientation, both of the patient as well as the technician changes. So communication between all the dots, the person, the patient, the clinician, the technician are very important. And these cause the errors. I'm not a technical person. I'm not a doctor, but this is my perception as a patient. And that's what I bring to the table. The perspective, and to me, WHO has created a fantastic forum of the WPSD. Last year, the theme was patient engagement, and I'm carrying this forward into this year as well, combining patient engagement with diagnostic safety. What's our next? So that the consequences of harm can come down. We all know delayed treatment, suffering, increased wrong treatments, wrong interventions. Nobody is at fault, and yet all of us are at fault. So can we combine ourselves? Can we combine our strengths and together deal with this problem without any blame, without any claim? That is not the idea. The idea is, can we work together to reduce the problems? And the next part, make it safe. This is what I mean by making it safe. It cannot be done alone. Next, Varsha. It has to be combined. We have to work together. So we analyzed. In our foundation, this was done 2-3 years ago. We entered this field of healthcare, and we were really impressed. I doff my hat at all of you. The dedication, the sincerity, the intelligence, the experience that you bring to the table. Where is the question of not trusting you? Of course we trust you. Of course we love you all. But do you love us back, or is it just a case number? Are we just a living cadaver on your desk? Please don't look at the computer. Look at me as a whole. That's another story. But we said, we can't teach you what to do. So we turned around and we said, let's teach ourselves what to do. You notice there's one green box and 2 pink boxes. This is the truth. We blamed, or we thought we'll blame, or we thought the fault was there. Of course, we are all human. We make errors without meaning to. That's medical harm. But then as people, as patients, as caregivers, we do even worse things. We don't tell you all in time. We ignore symptoms. We come to you late. We don't come to you at all. I've given you the examples. And if we did, perhaps we'd get better. So this screen led us to what we do. And I'm being honest in my next slide. What's the next slide? That I'm admitting here, as people, we blame the whole world, but we don't look inside. And exactly this is what our focus is in our Patient Safety Foundation. My health, my responsibility. I cannot just say my health is your responsibility. It's time that patients come forward, people come forward, the community comes forward, and we seek your help to teach the community to come forward, to help us, to remove our fears, to understand our vulnerability, to understand our lack of, our ignorance, our lack of awareness. And we offer you patient education material, which I'll just quickly go through because Ankita is going to give me the bell otherwise. But we do sometimes find fault in not giving you the right symptoms, incomplete, incorrect, or late. I have friends who are educated. They refuse to take a test because they say we'll find out something and we don't want to find out. Closing your eyes doesn't make the thing go. I think early diagnosis, early testing gives you early treatment. We miss appointments. Worse still, we make it. And this is a great slide. So therefore, I request you not, to me, the definition should have been wider than what it is. It is not only diagnosis in the hospitals. It is before, during, and after. Before, I've given you examples. If you do not report, or if you do not take the test, you will not know. But during, it is also the diagnosis process goes on during. It was my last chemo, second day of my last chemo. I had settled down with my IV. I suddenly was fainting, perspiring, became red and cold. My daughter was with me. She was not a doctor, but she knew there's something wrong. Can we call it diagnosis? Maybe. And she alerted the nurse. There was no doctor on call. They had all gone for a conference, just as the way we are sitting now. The nurse had her SOP. She revived me, and she came to the rescue because my daughter alerted. So diagnosis, symptoms can happen at any stage. I think if we are aware as people, if we are aware as a nursing community, as a medical community, I think we can all collectively work on a better thing. So we do this at every stage. We are creating patient education, patient awareness material, which says, next slide, symptoms, risks, next slide, because we do believe that we must cover, next slide. So we are not giving clinical advice. No, we do not want to go there, but we tell you when to take clinical advice. So that early detection, and if you don't do it, the consequences, we are alarming it, we are alerting people. And there's hope. We're giving you actionable tips, which we have taken from the wisdom of you people. Your best practices have been simplified, and we are taking a larger role for a patient and caregiver, not just rights, not just responsibilities, the role we play as human beings, as people in our own care. And within 1 year, we've got great traction. Lots of people, lots of corporates have joined hands. Hospitals are joining hands. We have just released a white paper 2 days ago by CAHO. The touch points in the patient care or the care journey, whatever you want to call it, or the patient journey, where you as professionals can interact with us, and we in turn interact with you, and together we make this movement successful. Next. So just to give you a quick glance at some examples, I'll run this through. Varsha, just run through the examples quickly. And for example, we are promoting PHCs with the basic tests, and we're doing this in text, we are doing this in graphics, we are doing webinars, we are doing videos, and common people, learned people, we have them translated in 12 national languages, how to recognize the stroke. You had some, I think you had many stroke places. Please share this, and if we share this in our community health, if we share this in accreditation, if we share this in all the populaces that we deal with next, I think we would be healthier, we would be smarter, and we would prevent rather than just succumb to it. I mean, for example, a heart attack comes on you suddenly, but a heart failure has given you warnings. We have ignored it. We don't listen to our bodies. Similarly, women's health. Different stages, different problems, different symptoms for different growth. Next one. So I'm just going to wrap this up. Next one. Yeah. So this one, for example, the power of imaging tests. I think people ignore it. I've taken an ultrasound. Why do I need an MRI? And this is what we are doing. This is how we are doing it. We are promoting healthcare. We are promoting it with safety. And we are trying to join hands with all of you, each of us. And please help us to reach out, teach us, reach us, not just treat us. And my advice to patients, get involved, become aware. Don't hesitate to ask questions. It is not you and us anymore. It is together. It is my responsibility as much as your responsibility. This is what we offer to make it safe for all of us together. You get it right, we make it safe. Please take a screenshot of this. There's lots more material on this. No time for that. But I think, I hope I've made myself clear what we offer, what we bring. And we need you. We seek your help. We seek your advice. And we seek your reach. Thank you, Ankita, for giving us that platform. Thank you for allowing us to speak. And I hope it makes sense. Thank you, everyone, for listening.
Thank you so much, ma'am. The compassion you have towards patient safety could be heard in your strong words. The work actually PSF is doing is awareness about the importance of health is commendable. You have definitely said the right thing. Prevention is definitely better than cure. So going forward with our next presenter, I would like to invite Dr. Zisem, who is an head at Department of Clinical Laboratory, Mongolian National University of Medical Sciences, and he's also an head at Center of Medical Laboratory, Mongol Japan University, and he has been doing the research and development projects over the last years on the different topics like neurosciences, feeding regulations, and stress. So I'm sure we are ready to hear him on the correct and timely diagnosis, which is the first step of preventing interventions and effective treatments. Over to you, Dr. Zisem. I hope I pronounced it right.
Okay, thank you so much. Hello, thank you for being here today. Very nice introduction to myself. Thank you very much. Today, I will share the critical role that timely, accurate diagnosis plays, preventive healthcare, and effective treatment. Let's dive into how diagnosis serves foundation better than health outcomes. I hope everybody can see my slides without any troubles. Okay, in here, I just share my experience, not studies. Okay, Let's begin by discussing the hospital staging system in Mongolia, which plays the crucial role ensuring the patients receive the right diagnosis and care at the right time. The healthcare system is divided into 4 stages. First one in family hospital. This is the first point of contact for most patients. It's at is the level that the initial health concerns are assessed and early diagnoses are made. The regional diagnostic and treatment centers, patients requiring the more advanced testing or treatment are referred here for future diagnosis and specialized interventions. The medical standards for specialties this stage, patients with complex conditions are seen specialists with access to more advanced diagnostic tools and treatment plans. University hospital, this is the highest level where academic medical centers provide the cutting-edge treatments and diagnostic research. Each level is designed to ensure timely diagnosis and treatment, starting at the community level and progressing toward more specialized care as needed. I think that these all hospital levels are similar to the India. And next, this is illustration organizes the structure with the hospital system in Mongolian National University of Medical Science. At the top, we have the hospital director who oversees various department categories that under for deputy directors. The first one is the quality and safety. Second one is the medical affairs. And next one is the nursing. The last one is the financial. Our medical laboratory is under the deputy director for the medical affairs. And this is our laboratory structure. At the top of we have the laboratory director who oversees multiple managers and each handling specific aspects of the laboratory operations. This included the infection prevention and control manager, quality manager, biosafety manager, training manager, and risk manager. Also beneath these managers are several specialist departments, including the hematology, coagulogram, biochemistry, clinical chemistry, such as the structure also highlights the role of the laboratory technician and biomedical technologist. This professional work alongside the clinical pathologist ensures that each testing progress contributing to the diagnostic process. Also, I would like to the Mongolian medical laws and the Mongolian healthcare system governed by set law designed to ensure quality, accessibility to equality healthcare. Some of the most important regulations, including the health law of Mongolia. This law serves the foundation of the healthcare system. It outlines the rights, responsibilities of patients and healthcare providers. It also established a legal framework for how hospitals and healthcare facilities operate, including the requirements for correct and timely diagnosis, as well as the rights of patients receive the appropriate care. Law of medical assistance and service, also including to ensure that all citizens have access to healthcare services, regardless of their social economic status. And medical ethical law, this law is critical ensuring that healthcare professionals uphold the highest ethical standards. It mandates that all diagnostics and treatments decisions are made the patient's interests in mind and stress the importance of informed consent of transparency in diagnosis. And these laws are instrumental in ensuring that healthcare providers delivered accurate and timely diagnosis, which are essential for both preventive interventions and effective treatment. Adhering this regulation not only improves the patient uh, outcomes, but also enhances the overall efficiency and trust the healthcare system. And also our hospital has the many policies, including the laws 19 policy. And also uh, our laboratory has so we have the many policy, and all use this all policy for the patient care policies use icons or illustration representing the patient care, such as the stethoscope, health or hospital building, along with brief bullet points highlight the hospital policies and the patient care. All the trained for it, we all new employments, we all trained for this. It's preventing to delay diagnosis, wrong action, all errors, and it's improved the right time, right sample, right test, right treatment, and also it's the evidence of the lab saved the life. And all our policy is divided the three processing. The first one is, of course, the pre-analytical process and the analytic process, and last one is the post-analytic process. The all stage is the included the when we inform to the doctors and patients and also our team and also the all staffs. The one is example is the regulating the post-analytic process and urgent examination of the DSL. The touch time for urgent is about 60 to 90 minutes. It's depends on the sample test analysis. You can send mostly is about the 45 minutes. The most long is the 90 minutes. And also we have the critical value reporting. It's divided the CBC and clinical chemistry and coagulation and immunology and immunohematology and biochemistry and including the microbiology. In here, I reported the last year in May, June, July what was the time of Argent test, and our CRP is the information number is the 354. Is we can inform that the correct time it's only the 84%. Then after we deciding the how to improve this one, and it's improving the information time number. And the next one is the urgent test, dividing the hematology and biochemistry, and the immunology is we can inform the 100% on the target time. In here, I shared to the one in vital science and physical examination, and one patient came to our ICU, and then here I showed the physical exam, and the body weight is 7.8, and interestingly, the heart rate is occurred to the tachycardia. And in biochemistry analysis, you can see the potassium is it's need to inform potassium and sodium ion level is critical value. Then we inform to the doctors it's occurred the critical value, and after the hematology testing, the leukocytosis and neutrophilia, absolute moderate microcytic and hypohoric anemia, thrombocytosis occurred. Then doctors decided to the emergency department, and interestingly, the acidosis, metabolic acidosis occurred. Then it's diagnosed correctly and advanced under the advanced monitoring and treatment. You can see the all test results becoming the good and healthy. And also the creatinine levels increased, and after treatment is becoming the lower. You can see that after treatment, blood pH is becoming the normal. After that, the 5 days the treatment, that child becoming the normal and leave the hospital. And thank you very much. Thank you so much.
Thank you, Dr. Zisser. It was very extensive with the technical details, and we have seen that a lot of things which are very required to be informed, and you have mentioned it very nicely. Thank you so much, Dr. Zisser. Going forward with our program schedule, now I would like Dr. Himshika. She's a corporate quality head, Sharpside Eye Hospital. She's an accomplished senior manager in quality with a proven track of over 16 years in healthcare management. Currently, she is working in Sharpside Eye Hospitals as a quality head, and she has taken strategic initiatives to ensure patient safety, regulatory compliances, and continuous improvement across multiple hospital locations. She has an expert of clinical quality assurance, accreditations, NABH JCI, the process improvement of SOP developments, patient safety audits, internal audits, and risk management and reporting. Thank you, Dr. Himshika, for joining us today, and please enlighten us with your expertise in patient safety and know about implications. You're on mute.
Thank you, Ankita. I think there's some network problem at your end.
Can you hear me?
Yeah, I can hear you. Can you hear me?
Yes. There is a little background noise at your place.
Just a second. Now, is that okay?
Yeah, I think if you can ask,
Is that okay?
yes, if you can go in a separate room, that would be fine.
Yeah, just give me a moment, please.
Sure.
Now am I audible, Ankita?
Yes, you can start. That's okay.
Yeah, thank you. I am Dr. Himshika, as Ankita said. Let me share my screen with you, then I'll start with my presentation.
I'm really sorry. There are very noise at your back. I think you can see the space till the time we can go forward with the other speaker.
I think that is much better. We are already running short of time.
Yeah, you can see the other space as well, right? So I'll go with the other speaker now.
Kita, you're on mute mode.
Geeta, you are on mute.
Sorry. So going forward, to space up our schedule, I would like the next speaker, Dr. Indu Arneja. I'm sure you all must be knowing about her. She is the founder director of the IIHC, Indian Institute of Healthcare Communication, an organization dedicated to improving healthcare delivery through training programs for doctors, nurses, and management professionals. She has taught at prestigious institutions and authored the book Fundamentals of Clinical Communication Skills to address the specific needs of Indian medical education. With over 2,000 training programs and workshops conducted, she has reached 50,000 participants, fostering patient-centric care. Recognized by the Academy of Communication in Healthcare, she has also run a successful master trainer program to develop healthcare communication trainers and actively share her expertise to various platforms, including YouTube. So I would like to welcome Dr. Indu Arneja and share her expertise of that how communication is very important in telling the patients about incorrect diagnosis. Thank you so much, ma'am. Over to you.
Thank you, Ankita. Thank you, KI, for the opportunity to interact with the audience. Patient safety has always been my concern because I think that should be the primary purpose of the treatment that we provide to the patient. Whether we do any good or not, but at least we should not do any harm to the patient. But I also note at the same time, there are a lot of situations where whether out of ignorance or out of any reason, there can be diagnostic error leading to the treatment error, and we know the outcome. And I think Professor Nadira spoke extensively on the harm that we cause to the patient. And I think I'm very happy, Professor Nadira, that you brought about the patient's responsibility, patient's accountability in making sure that they cooperate and they participate and they share all information, and they also know what all can cause damage or harm to them, which could also be irreversible. And if they learn how to identify these serious illnesses and they take a proactive action in getting the timely treatment and intervention, I think we can actually save a lot of lives. There is no doubt about what you said, and I'm very happy that you brought up that. And I would love to interact with your organization in any capacity, wherever I can participate or contribute, because even I believe in patient advocacy. I believe in patient safety, and I believe there cannot be any other person better than the patient himself or herself to ensure their safety. So I really
Doctor, that's a promise. Doctor,
Yeah.
there's a problem. That's a promise, and 48 witnesses here.
Oh, wonderful. Thank you. So, I mean, I'm very happy that this is now being part of the, the discussion that we are having across. But since I have been given the responsibility to talk about how do you go about communicating diagnostic error, which is, of course, I know is an equally challenging job for anybody, for any healthcare professional. Any kind of, medical error that happen in patient care, it could be medication error, it could be treatment error, it could be identification failure, it could be wrong dose, wrong route, wrong medicine, it could be anything. And I think these are all very sensitive communications. And incidentally, we are not trained for it. We are not prepared for it. So it's something like we believe this will not happen with me. I'm not going to face this. I don't have to be ready for this. But I think I must let everybody who is attending the program and anybody who gets to see this program later, please remember, I mean, problems can happen anytime. At least we should know how do we go about handling it. And a lot of situations can actually be de-escalated if we know how to proactively manage it. Of course, there is no substitute to, making sure that such errors do not happen in care. If we know how to go about following the protocols for making a diagnosis, I'm sure errors would automatically get reduced. And studies say that 50 to 80% of the diagnosis can be made if you ask right questions to your patients and you allow them to answer and you listen to them. I think these are a couple of things if we follow. These are the simplest thing which anybody can do. It does not require any technology or any innovation. But incidentally, we have become very reliant on technology and innovation and the tools and techniques. Like you said, 70% of diagnosis come from the investigative results. So that means I'm relying on so much on technology that my own clinical sense I'm not using. And anything that you don't use, it actually becomes obsolete. So not talking further on this because I know I'm going off track, but that's something very close to my heart. So I thought I must share with my audience. I definitely want to help people understand that there's a way to communicate. After all, if I have to communicate, I need to communicate. I need to learn how to go about communicating. So in my short presentation, I'm going to help you learn how do you go about dealing with such sensitive situations where we know anybody will be upset and hurt because we have failed in our duty, whether willfully or unknowingly or out of ignorance, or it's a team failure. But then, yes, we have harmed the patient, we have failed to do what we are expected to do, and we need to communicate. Again, we don't like to do it, but you can't escape the situation. And I know a lot of errors get, unnoticed, unnotified. Almost 97% of the errors are not notified to the patient. So the focus is primarily on not telling the patient, but that's not the key. The patients are very educated. They're aware, they keep an eye, and they can sense that there is something wrong and we are, not really attending or, sharing the right information with them. So when situation is that I need to share and I need to talk to the family, maybe this protocol that I'm going to share with all of you will help us to deal with this situation and see how we can handle the situation. So give me a second to share my screen with you and take the discussion further. And please feel free to ask questions and whatever thoughts you have around it. Give me a second, yeah. So I hope my slides are visible. My screen is visible to all of you.
Yes, ma'am, it's visible.
Okay, thank you so much. Thank you. Yeah. So as I said, my topic of presentation is communicating diagnostic error, and I know it's a very difficult task. But let me also tell you that according to WHO reports, 5 to 20% of the patients actually experience diagnostic error across the world, and almost 0.7% of the adult admissions, there has been identified a harmful diagnostic error where actually the patient has suffered some kind of harm at our hand. And also, let me remind all of us who are attending this program, most of us will suffer at least one diagnostic error in our lifetime. So the only way is that we need to be alert. Also, studies suggest that 39% of the lawsuits are about the diagnosis related. That means we are failing majorly on diagnostic tools, techniques, or the procedures. So let me come to the topic now, and that is diagnostic, communicating the error to the patient party. So I know it's not an easy job because it actually involves embarrassment, aggressive reaction, and of course, risk of litigation. And we know we have experienced a lot of time violence at the hands of patient parties where they can't control their emotions and they just want to blame us or they want to take revenge with us. And all that actually is very difficult to handle. So and when it comes to sharing, as I said earlier also, 90% of the doctors actually support the principle of disclosure, but honestly, only 31% of us are ready to do it in the right manner. So that's because we are not very comfortable doing it, and it's a very difficult situation to handle. So the guidelines that I'm going to share with you are based on the recommendations by the Canadian Patient Safety Institute and the UK's National Patient Safety Agency. And of course, you are free to, you modify it as per your requirement. These are just the steps that if we follow, I hope that we can handle and de-escalate the situation. So before we go communicating to the patient about the error that we have noticed in the diagnosis, it's very important to prepare ourselves before the conversation. So make sure that you have reviewed patient's medical history and the diagnosis process that you adopted to reach to the conversation, so that patients, when they ask you about it, what happened, what all did you do to reach to the right diagnosis, at least you are aware about what were the symptoms, what you thought, what could be the differential diagnosis, and how you actually reached to the diagnosis that you kind of finally chose to treat. Make sure that you gather relevant information and have a clear explanation ready. As I said, patients will ask you a lot of questions. Why didn't you do this test? Why did you do that test? What did that test tell you? What were the other possibilities? So that means I need to have very clear understanding of the explanation that I'm going to give to the patient party. Also, before you start having any discussion with the patient, it's always better to make them sit at a separate place, so ensure privacy and have minimum interruptions, because this discussion requires a lot of place where you are comfortable and there are no other people overhearing your conversation. And we see in a lot of hospitals, we do this discussion maybe sometimes in the OPD or sometimes outside ICU or outside ward or even sometimes at bedside. So this is not really advisable. It is better to have some side room or some counseling room if you have the place, so that you can have this discussion in a peaceful manner. At the same time, prepare yourself for strong emotions, because patient party is definitely going to react once they get to realize that we have gone wrong on making a diagnosis. And at the same time, we individually also go through a lot of emotional turmoil and overwhelmed emotions, because we somewhere feel embarrassed, we feel sad, we feel sorry, we feel guilty. So all those emotional, mixture can be very overwhelming for anybody to handle. So mentally, you really need to prepare yourself for the strong, emotions that will come from the other party, and also you need to, control or handle your emotions. Now, when it comes to delivering the news, I think the first and foremost thing the rule that we have to follow is acknowledge the error has happened. A lot of time we beat around the bush and we don't want to accept that we actually made an error. And that really irritates the patient party. And a lot of time they just want to hear this. Please admit that yes, error has happened on our hand. We have failed to make the right diagnosis. So in the beginning, if you straight away acknowledge that yes, there has been an error at our end, that kind of puts the that anger, and then also the tussle that you have to agree that you made an error, that gets settled. And now you know that I need to now further explain what exactly happened and how you reached to an incorrect diagnosis. So it could be anything. Maybe you got a wrong report, maybe it was a technical error, maybe you did not get the complete information, or it could be that you mistook him for another patient, or sometimes we know blood investigation for one patient are done for another patient. You all must be knowing kind of errors that we see in patient care. Reason could be anything. But I think admitting that yes, there has been an error, and then when you provide a straightforward explanation what went wrong and how the incorrect diagnosis occurred, I think that gives them an idea how exactly the thing went wrong. Make sure that you use simple and non-technical language, because when you use technical jargons, when you say, oh, the MRI report showed this and that was not for you and that was for another patient, or for example, Professor Nadira was sharing about her ultrasound report where it said that it is reoccurrence, but the doctor was very confident, oncologist was very confident, and he said no, nothing to worry. That means he was very clear about what he was communicating. Make sure that you don't use any medical jargon, because especially they are overwhelmed. Naturally, these technical jargons, they do not know. And when you are overwhelmed, you're not actually listening and understanding what is being said. So when you explain in a simple and non-technical language, it may make sense to them. When you're talking to them, make sure that you use frequent pauses. So what happens when we are apprehensive or when we are in hurry, we like to tell everything one after the other. Please listen to me. Let me explain to you. First, let me explain everything and then you ask question. I think that will not work in this situation. Use frequent pauses. Give them time to, understand what you are saying, because as I said, they are overwhelmed. So there's a cognitive deficit. So they may not exactly understand, and they may take time to assimilate what you are saying. So give them time to listen, understand, and also maybe in between they want to ask something. So make sure it is a dialogue kind of a thing. When it is a dialogue, you get to hear what they are saying or what they are thinking or what is on their mind. And when you think, oh, let me complete saying whatever I have to say so that I have clarified my stand. But if they have a question and that question is right here, trust me, they are not listening to you, because they are feeling suffocated here and they have a question and they also have a fear. I need to ask this. I need to clarify this. So it's always advisable to have a dialogue where you say something, let them assimilate, and then maybe in between, if they want to ask you a question, give them a chance to ask and clarify. And then when you're answering, please make sure that you answer those questions honestly. Anywhere if you try to deceive, anywhere you try to cover up, they can make out. Your body language, your tone of voice, your expression actually will give away. So it's better to tell honestly what exactly happened. If you mistook this patient for another patient, or if there was a technical error, or if there was an error at the lab, or whatever it was, I think it's very important to answer those questions in a very, very honest manner to them. when it comes to taking responsibility, a lot of time we have a tendency to say, oh, my team did this, oh, my technician did this, oh, my nurse did this. I think we have to understand overall responsibility lies with me if I am the treating doctor. So I have to take this responsibility rather than saying, oh, somebody in my team did not realize this, somebody in the lab did not realize this, oh, I think the mistake happened at the ultrasound station. That won't help in that situation. Then they will say, who is that person? Call that person. I want to see that person. I want to talk to that person. It is better to say that since I am your treating doctor, and I think it's my responsibility to make sure that these things were done in a right manner. So if you try to blame or speculate that maybe somebody did this like this, again, they're not going to take it, and that will not go in a very good taste with the patient party. So taking responsibility actually shows that you are taking responsibility of whatever has happened. And at the same time, make sure that you express empathy and also apology. I know a lot of you must be thinking about apology, and there are studies that say that people are, or doctors are actually afraid of apologizing because somewhere there's a fear that if I apologize, that means I am responsible for the error. But make sure when you first of all understand their feelings and validate their reaction. So anybody will be upset. Tell me, will I not be angry? Will you not be angry if your doctor went wrong or if your treating team went wrong? So if you say, yes, I understand, I think anybody in your place would feel the same. That would help them see that, yes, you are understanding even their feelings and you are okay with the reaction they are coming. And from there, if you take their focus to the patient's welfare, they would understand that, okay, now you're focusing on what best can be done. So when you express personal regret or personal responsibility and you apologize, I think that really lightens the situation. So say, I know whoever has done it, but I think primary responsibility is mine, and I am really sorry for what has happened. That would actually make your position higher in the eyes of your patient, that you are ready to take responsibility, even if it wasn't your fault. So actually, apology has two meanings. A lot of time, for example, if there is a mixing of report, and as a result, you made a wrong diagnosis, or there was a technical error. So actually, that isn't exactly your fault. But when you say, I'm sorry that this has happened in our case, so it's more of an expression of compassion. Although you are not wrong, but you are taking responsibility. But a lot of time, if I have failed on something, I did not notice the report, I did not check with the patient, or I did not check with my lab, then it's my responsibility, and it's actually expression of responsibility. But in both these situations, let me tell you, sorry works, and a lot of studies have shown that when you say, I'm sorry for what has happened, they actually feel that, yes, we can understand their suffering and we are with them. And that's a very good way of handling that situation. A lot of time we apologize for the sake of apologize. And that's where the apology actually will fail. So that kind of apology is not helpful in any way. For example, if you say, if there was an error, I think I must apologize. So that's not an apology. Yes, there was a mistake, but this kind of thing happens when we have a lot of work in the lab. Again, this kind of apology is not going to help. The mistake certainly did not change the outcome. In any case, the patient's platelet count was, already very low, so there wasn't much change. Again, this kind of apology is will not make any sense. And also, when you say sometimes, these things happen when we have a lot of patients. In your case, we had another patient with your name, and the reports got, mixed up. So they would say, don't you have a system to check that the correct report is actually attached to the correct file? So such kind of apologies are not going to help. Make sure that when you apologize, it's actually a very genuine apology, understanding that, yes, a harm has happened to the patient at our hands, and we are collectively responsible for that. And especially when you give a stiff apology, it's actually adding insult to the injury. So that's not something that the patient is expecting from us. Patient wants to be healed because he has been hurt by us. So make sure that your words, your tone of voice, your body language actually communicates that you are feeling sorry and you are ready to make amends. The next step is now to see what can be done to minimize the damage and what kind of support you can provide. So that's where we actually explain to the patient party what steps you have taken or you are going to take to reach to the correct diagnosis, and then make sure that how the patient gets the proper treatment. At the same time, explain what we are going to do to minimize the damage. For example, some treatment that you have already started based on your previous diagnosis. So what are you going to do to minimize the damage? If you think, yes, some damage has happened, could be reversible damage. So what are you going to do to minimize the damage? Then also the make sure that you provide them reassurance of continued support and care. And then when you say, I know this has happened now, but from here onwards I'll personally make sure that the patient gets the right treatment and the right attention, and I'll stay in touch with you, you stay in touch with me. So what you are saying, that not only now I'm going to make amends, but I'm going to make sure that all future interactions actually are looked after. At the same time, it is very helpful to, a lot of time they don't speak up, maybe out of fear, out of respect, or being confused. So it's good to invite them to a question. So if you ask them, do you have any question? Now, what are your concerns? I know it has happened and we are going to do what best can be done, and we are going to minimize the damage that has happened because of the wrong diagnosis. But do you have any concern? They will have definitely concerns because they are worried about the damage. They're worried about the recovery. They are worried about the delayed diagnosis or delayed treatment. So those concerns, when you're able to scientifically answer and address, they will feel that, oh, things are being looked after now, and there is an opportunity to reverse the damage, or no significant or serious damage has happened. So these things will actually make them comfortable and less anxious, and then align with you. And then tell them that how you're going to meet the needs of the patient and the family, because maybe you need to put the patient now in the ICU. So the patient is not going to be, not in the room, but in the ICU. And then you kind of tell them or explain them that we will let you see the patients once we are able to settle the patient, or I will keep informing you, updating you maybe in every 2 hours, so that you are informed about the condition. So that's how you are going to, support and provide them continuous support. And then make sure that you are accessible. A lot of time after such kind of interactions, we try to become little aloof or stay away from them. We hesitate sharing our number. We like to interact less. So that shows that probably we are not only guilty, but we have done something willfully, and that's where we are hiding from them. So I think in such a situation, it is advisable that be accessible as and when they want to connect with you. And if you offer them that, okay, I'm available during these hours in the OPD, in case if you have any questions, you can come to me, or these are the timings when I'm available in my room, you can speak to me, or there will be somebody to answer your question. That will tell them that there is a continued support provided by us. Then once we have discussed everything, we have explained everything, what you are going to do, how you are going to reverse the situation, what is the right diagnosis, and what you are going to do to make the right diagnosis, it's important to make the follow-up plan. So when you make follow-up plan with them, it's important to discuss, as I said, how you're going to meet the needs of the patient. And also, if you feel the patient party is very apprehensive, or the patient himself or herself is very anxious, if you have counseling services or a social worker or some system where you provide mental health support to the patients and their family member, you could actually even offer those services if they're available in your hospital. Because a lot of time, they may not be comfortable sharing all their concerns with you. It could also be about the treatment cost. It could be the longevity of, the stay in the hospital. So whatever their concerns are, and if you have some way to address those concerns and somebody to listen to them, they would feel that, yes, they are being given an opportunity to express their concern, especially if they are not very comfortable to share with you. After you have done all this, I think it's very important, as I said earlier also, that you should be, accessible, you should be available. I think that's something that patient really looks forward to you. Now, once you have done everything, it's very important to document whatever you have done. So make sure that you report the incident and whatever actions you took. At the same time, whatever clinical decision you took to reverse the situation, to make the right diagnosis, the right treatment that you have, ultimately implemented, whatever is the clinical outcome and whatever the further plan of action that you are thinking of, all that has to be documented so that it becomes an evidence of whatever you have done. The discussion that you hold with the patient or family, make sure that the names of the people who were there in the discussion, it could be the parents, it could be husband, or it could be anybody from the family. Make sure you write their names and the relationship with the patient. and questions they asked you and the answers you gave them. So it becomes more like a, an evidence that there was an error, and we discussed and we informed, and this is the corrective action that we have taken. So and also make sure that you sign and date and write your contact details, so that in case if they want to get in touch with you, there's a way to contact you. This is very, very important. Make sure that you follow the protocol. And once you have done everything, I think the first and the last thing that should come to our mind is sit and reflect. It's very important to learn from what has happened. Don't just, move on with it, but rather sit and see how you're feeling now. How are you feeling in this situation? How did you perform that disclosure of error? What were you experiencing in this situation? There's no harm discussing with your colleagues, because they can give you a lot of inputs, not only in making the right diagnosis, but also in how do you go about communicating this situation with the patient party, because these are very intense communication. And then make sure that you keep reading material to update yourself, because a lot of protocols are available, a lot of guidelines are available, how to go about doing it. Attend programs to learn how do you disclose errors, how do you break bad news, how do you handle crisis situation, how do you handle emotional outbursts. So once we know how to do it, I think we'll be more comfortable dealing with such situation. So I know as of now, we are not very open with the idea of disclosure, because we think disclosure should be avoided. But let me remind you, a lot of studies have been done where hospitals have gone with full disclosure, policy, and actually their litigation cost, their, the loss, revenue loss actually got reduced. Even the patient trust increased, where they came up with proper disclosure. So actually, disclosure promotes transparency and it builds trust with the patient party. It enhances patient safety, and it also prevents future incident. So something went wrong, we learn from it, we make sure it doesn't happen next time. We discuss with our colleague, even they get alarmed. But if we don't share, if we don't discuss, then you made an error, you learn, but others will continue making similar errors in future. So it will also improve the quality of care. I'm sure you will go into root cause analysis and also take a corrective action and preventive action. So that way, when we continuously do, it's a continued quality improvement, and definitely the patient care will, become better qualitatively. Also, it will meet the legal and ethical requirement. It will prevent litigation coming from the patient, and it will strengthen the patient-provider relationship. It will also facilitate healing and recovery, because ultimately it does affect the patient, majorly, because anybody going through this would be anxious and panicking that what is going to be the outcome. So to quickly summarize the last slide I'm sharing with you, make sure that you prepare yourself for the conversation, deliver the news in an honest and compassionate manner. Don't hesitate taking responsibility, express empathy and apologize, explain the next step and support that you can provide, invite questions so that you get to understand what they are thinking, and then also make sure that you make a follow-up plan together with them so that they are in touch with you and you are in touch with them. Document whatever you have done and reflect on it. Thank you. Thank you. So let me stop sharing. Okay.
Thank you so much, ma'am. Thank you so much for the very apt presentation on the topic. I do want to add that this communication is a very important topic when it comes to the patient safety. Communication is not just the words, but it will also include words which are very impactful. And most of the time, patients are maybe not understanding and listening to your clinical terminologies, but they are listening to your tone of the voice. I think that is very important, and that creates a very good impact. Thank you so much for enlightening us on this. So I would like to now, going forward the schedule, and definitely we are a little late on that. So I will ask Professor Sutten Sarvadhikari, sir, to please come on the presentation. And about the sir, he's a very known TEDx speaker, and he also chairs the section committee of active assisted living. He is also taking co-chair of task force on AI in healthcare. He's a name in AI industries and advisor of School of Digital Health. He's an expert member of Roster for Digital Health, WHO. He's a former project director in Center for Health Informatics. He's a former chair HL7 India, and he former faculty of IIT Kharagpur. So I would like to now give the presentation to sir, and please enlighten us of role of digital intervention in enhancing patient safety. Over to you, sir.
Thank you very much, Ankita. I'll share my screen. So is the screen visible to everyone?
Yes, sir, it's visible.
So good afternoon, everyone. As it has been already told, today is the World Patient Safety Day, and this year's theme is improving diagnosis for patient safety. The slogan is Get It Right, Make It Safe. Just a thing that where we are heading towards. In fact, there has not been any healthcare 1.0 what we know of, but in retrospect, we call it. So that was patient encounter, diagnosis and treatment. What was the conventional modern medicine, how it started. Then we came to healthcare 2.0, where we got the medical equipment and monitoring devices coming into play. Then we reached the health record, healthcare 3.0. That's when we have the EHR, electronic health record, the CPOE, that means the computerized provider order entry, remote care, telehealth. So we are very much into the healthcare 3.0, moving towards healthcare 4.0, where we have smart health, connected healthcare, personalized medicine, artificial intelligence, all these things are coming. So we are partly into the healthcare 3.0, healthcare 4.0. In fact, healthcare 5.0 is around the corner with 5G connectivity being a reality. It's being rolled out throughout our country. What Ankita referred to, actually, I've been a member, co-chair of this task force for AI on healthcare for the National Academy of Medical Sciences. Last year, we brought out this report. Also, the Indian Council of Medical Research brought out this ethical guidelines for application of AI in biomedical research and healthcare. So what essentially it means that patient safety, I mean, safety when we talk is not just patient, but also the safety for the healthcare professionals. And with digital health getting a preponderance of AI, ML applications, definitely the safety concerns also hinge upon the ethical issues. So we need to be very careful. It's a double-edged sword, but we need to use it judiciously. So when we talk about digital health, the term is not very new, but the division of digital health was formed by the World Health Organization just about 5 years back in 2019. And they brought out the Global Strategy on Digital Health 2020 to 2025. If you see the definition of digital health in that document is the field of knowledge and practice associated with the development and use of digital technologies to improve health. What we earlier used to call information and communications technologies, now we usually club them under the umbrella term of digital technologies. And whenever we are applying that for use in improving health, that is digital health. So it's a very broad definition. So e-health or use of the internet for healthcare, m-health or mobile health, telehealth, everything, telemedicine, teleeducation, telesurgery, all come under this ambit of digital health, which is a very huge spectrum. In this regard, one of the things which the global strategy talked about is every country should have a national digital health blueprint, and India brought it out in November 2019 itself. The vision of the National Digital Health Blueprint 2019 is to create a national digital health ecosystem that supports universal health coverage in an efficient, accessible, inclusive, affordable, timely, and safe manner through provision of a wide range of data, information, and infrastructure services, duly leveraging open, interoperable, standards-based digital systems, and ensuring the security, confidentiality, and privacy of health related personal information. This is the vision of our National Digital Health Blueprint of India. In fact, there have been lots of recommendations for digital interventions also for health system strengthening from the World Health Organization. In fact, we have been also writing about it. We have a few publications on the need for developing technology-enabled, safe and ethical workforce for healthcare delivery. When we talk about safe healthcare, what is very important is we also need to exchange the health information. And for exchanging it seamless all across time and geography, we definitely need interoperable standards, which have to be harmonized. So these are some of the standards which I'm showing here, right from the personal health devices, the wearables like Fitbits and Apple Watches, to the hospital or the clinic. If it has to reach there seamlessly, the patient will demand we should be able to access it wherever we are in this global village. And that is possible only through the use of standards. Now, how can digital health improve safety? So one of the ways is definitely implementation of electronic health records. Then the healthcare providers can access the details in real time from anywhere. And obviously that also helps in minimizing the cases of medical errors. Another thing is the clinical decision support system. That can help doctors and other clinical care providers choose the right treatment plan, since it provides alerts or suggests recommendations about the possible drug use by consuming a particular food allergy, drug-drug reactions, drug-food reactions, drug-disease reactions, and all these things can come through the decision support systems, which can definitely aid in proper management. There have been also issues about digital safety. I mean, just if you put an intervention, how safe is that? So that itself, again, you can see this journal itself is called Future Healthcare Journal. So we are definitely not looking at the future, but we are into the future. And there, of course, healthcare safety will also include the digital safety. When we talk about this digital health interventions for enhancing patient safety or preventive primary care, so this is a fairly recent scoping review. And there have been lots of studies going on, and obviously more study is needed. But it is now being recognized that digital health interventions can actually help in safety, preventive care in a very big way, provided we use it properly. This is a case study from this Quality of Care journal. This is about 6 years old, but it's a very relevant one. It's a EHR-based real-time analytics program for patient safety surveillance and improvement. So even for patient safety surveillance and improving that, EHR-based real-time analytics program can be helpful. Now, if you look at the regulatory scenario in our country, the third edition of our national health policy, which came out in 2017, had proposed the setting up of a National Digital Health Authority. For that, we had even drafted a bill, the DISHA, Digital Information Security in Healthcare Act bill. In 2018, March, it was put in the public domain for comments for a month. And that was talking about setting up the National Digital Health Authority. However, it was withdrawn in favor of the Personal Data Protection Bill 2019. That was presented in the parliament, then it was sent to a joint parliamentary committee, then the COVID-19 pandemic happened, and it got delayed, modified, reintroduced. Finally, it became an act last year as the DPDP Act, or the Digital Personal Data Protection Act of 2023. And the rules are yet to be framed, but once we have the rules, particularly for the health sector, I think that would be, again, a very important area which would talk about the safety for digital health interventions. So I think that's the end of my presentation. I'd be happy to answer any questions if you have. Okay, thank you. Over to you, Ankita.
Thank you so much, sir. It was really a nice presentation, and we all understand and we have seen that AI in the digitalization of healthcare, it's going to be a boon. And of course, we need HI also in this human intervention because everything AI cannot be done. So going forward with the next speaker, I would like to invite Dr. Sameer Syed, who brings the 16 years of expertise in hospital management, combining a robust educational background, and he's an MPhil in hospital management. He has done many courses like human resources and then diploma in business management. He's a proven CPHQ, proven track record in healthcare administration. His career has been marked by excellence in strategic planning, leadership, positioning him to optimize operational efficiency, elevate patient care outcomes, and drive sustainable organization growth. Currently, he's working at Marengo Asia Hospital as a head quality. So I would like Dr. Sameer to please come forward and share his expertise on diagnostic approach towards patient safety, role of a hospital's SOP. Over to you, sir.
Yeah, good afternoon, everyone. I'm very excited to hear today about discussing the critical topic of the patient safety. Today we'll explore about the diagnostic approach of the patient safety, how the standard operating procedures have playing the vital role in ensuring the safe environment for the patients. So let's move on. So now
Dr.
the world fair, yeah,
Dr.
am I
Sameer,
audible and am I?
we are
Okay,
unable to see
welcome.
your presentation. Can you please reshare again? Yes, we can see now.
Yeah, I can see. Okay. Now now today is a World Patient Safety Day. To raise the main aim of the opportunity we will get today is the awareness and the fostering the collaboration. How we are moving forward and what we are going to do for the society, what we are doing for the patient safety, being a healthcare leader in the quality and being a quality person, where in the organization where they are keeping and they want to do something for the patient safety. We are here, we are doing something for the society. So this is our day. We are doing something for the patient safety. As the World Health Organization has, the aim of this is improving the diagnosis of the patient safety with the slogan of get it right. So now we move on to what is the patient safety, how it is dealt. The patient safety refers the prevention of the error, which the adverse effects associated with the healthcare day to day. What are the instances are going on? What study of the World Health Organization have indicated the million of the patients are harmed every year due to the unsafe care. The highlight of the urgent need of the effective safety management measures are required. The requirement of the clinical pharmacist are required to check the audit and they to the nursing staff giving the nursing without after the verification of the patient safety protocol should be there. So these are the safety points should be keep in mind for the patient safety point of view. The theme of the diagnostic approach for the patient safety is the diagnostic approach involves the systemic identification and analyzing the risk of the patients. For example, in a hospital which experience a risk of medication errors, a diagnosis approach would involve the gathering the data, how the risk was involved, how to involve after root cause analysis, interviewing the staff, identifying the root cause analysis. Such a unclear labeling and inadequate training are there. So the main role, but the role of the quality persons and the quality team and the stakeholder, what are the roles for the patient safety? What are the standard operating procedures are very essential to establish the clear guideline of the staff to the follow. For example, as an SOP of the medication administration, might include the step like verifying the patients, checking the medications against the prescriptions, and documenting the administration, ensuring the consistency and reduce the risk of error. Which type of medication errors are there? Is the transcription error, prescription error, verifying against this. So these all things are written on the SOPs. And when you are preparing, being a stakeholder, you involve from the ground level, the staff of the nursing, CPs, consultants and nursing staff, all stakeholders should be there to form a SOP for the clear implementation. Now, how to implementing and monitoring of the SOP? So develop effective SOPs involving the collaboration among the healthcare professional. Healthcare professional include your pharmacist, your nursing staff, your ICN, your clinical pharmacist, and all are involved. Once the SOP is created, training sessions should be required to implement in the entire hospital. Okay, these are the policies which we are going to implement into the hospital. Now, after implementing, there is a part comes the monitoring. Okay, when you are implementing the thing, they are working on the ground level or not. The question arises like that way. So regular audit can improve the compliance. For the instant in audit reveals that the 80% of the staff, if they are following, then the 20% remaining required, they also need a training, and the refresher training also required. Now we move on to the challenges. When you implement the policies, you started auditing, then monitoring the things, then what are the challenges you are going to face and how you overcome from the challenges. So one of the challenge in implementing the SOP is the resistance from the staff, because whenever the staff who are working on, they are practiced in their college life till the different institutions. Yeah, these are the policy, these are the things we are doing in the other organization. These are we taught in our schools and the colleges. So there is always a resistance to change. So that is the main challenge. Then how to address this? The hospital can involve the staff from development of SOP. Once you are making the policies, you involve those staff to give your ideas. After brainstorming, you get the different ideas and then involve their wording, their points also. If they are in the SOPs, they feel valued, that management took our inputs in the SOPs, so they are going to implement. And when they are in the senior position or the new staff who are coming to the organization, they will teach them and they are feel that they are valued, their inputs are taken into the SOPs. Now, there are some few tips to implement the SOPs. First of all, is the involvement of the stakeholders. Engage all level of staff in development and review of the SOP, ensuring the practical and regular training should be there, because it's not one time of effort. Regular training, regular follow-up as there, pre-port test are there after implementing the policies. What are the ground results? And then the review and update regular. There are updates are coming in the pharmacopoeia and for the PBPI. If there is any changes in that, according to the SOP should be changed. So these are the things. The first is the SOP implementation, making of the SOP, involvement of the staff. Second, the implementation. Then the monitoring are there, and then comes the regular trainings and everything. Now, in my conclusion, the things are that prioritize the patient safety for a diagnosis is a robust. The SOPs is crucial for improving the health outcome. I encourage everyone who are in the quality or in the hospital sector to strongly advocate the strongly patient safety protocols in the hospitals. Diagnosis team efforts are the efforts which are taken by every one of the hospital stakeholders, the staff nursing from the CPs, and everyone should be involved. They should be brought into the one platform, and then you involve them into day-to-day activities, and then the SOPs are prepared, and then SOPs are implemented. SOP should be regularized. SOP should be again and again checked every year, or whenever there is a requirement of changes there, then SOP should be changed accordingly. These all data are taken and referred from the WHO and the AHRQ. AHRQ have also developed certain tools for the diagnostic safety, as well as the where they're involved the nursing staff, clinical safety tools are there. So quality persons who are working and who are right now present, they can go refer the AHRQ tools also. Now, with this, I conclude my today's webinar. If any question, they can ask me any question related to SOPs, because SOPs are the main thing which we are written guidelines in the hospitals and which we are implemented in the hospital. Thank you, Ankita.
Thank you, Dr. Sameer. It is again a very apt presentation on the topic, and I strongly believe that SOPs, standard operating procedures in an hospital, plays a very vital role, and it should not be only in the books, and it should be always implemented because we write SOPs, but the implementation sometimes are missing. So yes, definitely as a quality manager, I'm sure you people are doing at your hospitals the best you can do. So
True.
going forward, our one of the speaker, Dr. Himshika, I'm sure everything is okay at your place. So now we can go forward with you. So I would request you to please carry forward with your presentation. Thank you.
Thank you, Ankita and QAI. So my topic for today's presentation is implications of correct diagnosis on patient safety. The implication of an incorrect diagnosis on patient safety are profound and far-reaching, affecting not only the immediate care and treatment, but also the overall well-being and trust of the patient. So here are the following consequences. Delayed or inappropriate treatment causes harm to the patient by delaying the initiation of the correct treatment. Patient may be treated for the wrong condition, leading to their actual illness progressing unchecked. Disease progression, misdiagnosis often leads to the actual disease worsening, potentially resulting in irreversible damage or even death. Secondly, increased morbidity and mortality. Serious health consequences can directly lead to inappropriate treatment, causing patients to experience serious side effects or complications from unnecessary medications or procedures. In some cases, it can lead to death, especially in critical or emergency situations like stroke and heart attacks. Surgical and procedural risk. Patient may undergo unnecessary surgeries or even invasive procedures based on the wrong diagnosis, exposing them to risks such as infections, complications, or even death. Psychological and emotional impact. Anxiety and stress. A wrong diagnosis often leaves patients in a state of uncertainty and stress, particularly when the misdiagnosed condition is serious. They may endure unnecessary psychological distress over a condition they do not have, or even frustration from receiving ineffective treatments. Erosion of trust. Patients may lose trust in healthcare providers and the system if they are frequently misdiagnosed, potentially leading them to avoid seeking medical care in the future. There's also an increased healthcare cost. The financial burden due to more testing, repeated visits, unnecessary treatments, or even hospitalization, increasing costs for both the patient and the healthcare system. The economical burden extends to longer recovery periods and possible disability from untreated or improperly treated conditions. Resource wastage. Misdiagnosis results in unnecessary use of medical resources such as lab tests, imaging, and medications, contributing to inefficiency and higher healthcare cost overall. It also compromises patient safety culture. Diagnostic errors as systemic failures. The incorrect diagnosis often reflects system issues in healthcare, such as communication breakdown, inadequate use of diagnostic tools, or failure to follow clinical guidelines. This undermines the safety culture within healthcare organization, preventing the continuous improvement. It also causes failure to learn from errors. If diagnostic errors are not properly analyzed or reported, the healthcare institution misses opportunities to learn from them, potentially allowing similar mistakes to occur in near future. Legal and ethical implications. Malpractice claims. Misdiagnosis is a leading cause of medical malpractice claims. If a patient suffers harm due to incorrect diagnosis, healthcare providers may face legal action, which can be costly, damaging to their professional reputation. The ethical dilemmas. Healthcare providers are ethically bound to provide the best possible care based on accurate diagnosis. When a misdiagnosis occurs, It raises ethical concerns about transparency, accountability, and the patient's right to informed decision making. Loss of trust in healthcare providers, erosion of professional credibility. Healthcare providers and institutions that are frequently involved in cases of misdiagnosis may suffer reputational damage, leading to a loss of trust from both the patients and the peers. Impact on patient-provider relationship. Misdiagnosed patients may feel betrayed or neglected by their providers, leading to strained relationship and dissatisfaction with their care experience. Impact on healthcare providers. Moral distress. Healthcare professionals involved in cases of incorrect diagnosis may experience moral distress, especially in misdiagnosis, leads to serious patient harm or death. This emotional burden can contribute to burnout and negatively affect their well-being. Damage to their professional reputations. Physicians and other healthcare providers may face damage to their professional standing, particularly if misdiagnosis leads to legal action or public scrutiny. There's also impact on public health. Public health risk, incorrect diagnosis in contagious diseases such as infectious diseases can result in improper isolation or treatment, increasing the risk of outbreaks or public health emergencies. Obviously, it is also the barrier to continuous quality improvement. Stalled safety initiative. The diagnostic errors can hinder patient safety initiatives aimed at improving quality of care. Healthcare systems that fail to recognize and correct diagnostic errors miss opportunities to refine diagnostic protocols and processes, limiting improvement in care delivery. In the end, I would like to conclude that incorrect diagnosis pose severe risk to patient safety, leading to delayed treatment, unnecessary procedures, increased morbidity and mortality, and obviously eroded patient trust. Addressing diagnostic errors through improved clinical protocols, technology, collaboration, and continuous learning is essential for enhancing the patient's safety and delivering high quality care. That's all from my side. Thank you so much. And thank you for your patience listening. Now over to you, Ankita.
Thank you, Dr. Himshika. It was really a nice presentation. We have learned about the implications of incorrect diagnosis on patient safety. Now, going forward with our program schedule, as we are a little delay in that, I'm really sorry and apologize for that. But I'm sure that our the further speakers, and that would be more interesting to you because they will be sharing their case studies of the hospitals, that what exactly they are doing in their hospitals and improving the diagnosis and working towards the World Patient Safety Day theme. So going forward, I would request Ms. Rehma, she will be the moderator of the second session, to carry forward with this and start with the case study. So the case study will take 8 minutes. I would request all the speakers to focus on their progress, what they are doing toward patient safety, and our panelists, and so that they can be given 2 minutes and they can come up with some kind of solution, scope of improvements, because it is a knowledge sharing thing and we all are expecting something to learn from this. So going forward, Ms. Rehma, please take over. Thank you.
Thank you so much, Ankita. So we had a very good first round. Thank you to all the speakers for today on this World Patient Safety Day. You made this session enlightening for all of us. I'm sure for the audience who is available right now. So moving on to our round two, I would like to welcome our panelists, Ms. Nadira, Professor Suktendra, Dr. Sumesh, Dr. Sameer, and Dr. Indu, who is going to, share their views after the completion of the case studies. So I would like to welcome our first presenter, Dr. Sharad Verma, who is Director of Operations from ACE Gastro Care and Multi-Speciality Hospital, Prayagraj, accredited under small hospital accreditation program already. So over to you, Dr. Sharad.
Rehma, I would request you to share the screen. I have already sent my presentation because due to heavy rains, the net is very poor at my end. And this is the third system I have logged in 1.5 hours. So please share the presentation at your end.
Doing so.
So thank you, QI, for giving me opportunity to share all the experience at my own hospital, where we have developed many things, and the standards which we implemented for the accreditation process was highly helpful in getting very significant changes, which has finally resulted in better diagnosis, better patient care, less errors, and naturally a very good training atmosphere and working atmosphere amongst all the workers and consultants at our hospital. Next, please. Is gastrocare gastroenterology setup, but we have other specialties also, and we are proud to say that we are the first accredited QI accredited hospital in India. Next, please. You can skip this. Next one. So what we are basically using, that is more important. So we have developed some simple tools, like we are following certain clinical guidelines, and then we have customized our software in such a way that it's really helps in getting the accurate diagnosis. And naturally, all the clinical guidelines, they are evidence-based tools. And in our software, we have customized symptom-based software we have customized, which flags potential errors if they are missed by the team of doctors. Otherwise, even in, say, for gastroenterology, we have 3 consultants working together. Every patient coming to the hospital is going through all 3 consultants. And finally, all the decisions, they are taken in a cumulative view. And all the orders we have in a computerized form. Naturally, the orders are more legible, they are complete, and it's in a standardized format. So the possibility of error is reduced in such cases. And computerized physician order entry further enhances the efficacy and safety of the patient care. Next, please. We are continuously conducting training of all healthcare professionals to keep them updated about the latest diagnostic techniques, tools, guidelines as per the standards on QI, and other evidence-based tools are used to achieve better outcomes. The staff is sensitized at introduction of any new equipment, and that we have started only the implementation of the guidelines, the standards of our accreditation body. And application training is being provided to all the concerned staff and consultants when any new thing is added. And after the first accreditation, we have added multiple things in our organization, and it is this process is continuously helping us. And we are conducting CMEs, the local CMEs, and even the national CMEs. We conducted last year. We conducted one CME, and I'm happy to see Dr. Indu Arneja was one of the orators. It was a very prestigious oration which is run by the medical college from where we all have passed out, the Allahabad Medical College. Next one, please. So collaborative care approach. I just told you that we have introduced a system of collaborative environment. Different specialists are working together, and final diagnosis and everything is reached by the consensus of all the consultants. So it significantly minimizes the errors. And the interdisciplinary team provide a more accurate and comprehensive evaluation, early diagnosis, and naturally reduces the possibility of any kind of diagnostic errors. The next one, please. This is very important. We have developed a very structured communication system between the patient and healthcare providers. We have a specific counseling room in the outpatient departments itself, and a separate counseling room for the inpatients also. And we encourage the patient to share all relevant symptoms and medical history, and naturally we listen them very carefully. All the staff is being repeatedly trained on such processes, and we ask all the follow-up questions, or the staff is asked listen the patients very carefully and tell them each and everything, and take out the history by the process regarding the disease or the symptom about the previous treatment at other hospitals also. We are continuously doing this. Next one, please. So we have developed a standardized diagnostic protocols and checklists to ensure consistency and reduce the variability in the diagnosis, and that is with the software itself. The software used at our hospital is absolutely customized, and we are doing it like that. Healthcare providers at hospital are continuously trained to adhere to these protocols, and if any new employee joins our organization, he is also sensitized, and the existing staff is resensitized regarding all these protocols. And we have got all standardized checklists, and each and every staff has to fill that checklist, so the possibility of missing anything is minimized to a great extent. Next one, please. Second opinions. We always tell the patient that they have a right for the second opinion, and if they want to opt for that, they are free to consult any consultant outside the hospital or even inside the hospital, wherever they want it. And it has been proven really very effective in diagnosing the complex cases. When there is a group discussion among the doctors and the opinion on two consultants on some critical issues, certainly the errors in the diagnosis and management of the treatment, and finally outcome of the treatment, and possibility of elimination of misdiagnosis, that is increased to a great extent. Next one, please. Next one, please. The health hospital or veterinary reporting diagnostic error, near misses, no harm, and adverse event, and certainly it provides us the culture of safety. All the diagnostic error, near misses, even it's a no harm or adverse event, they are analyzed, and we keep a data of that, and that is discussed in the meetings, which are shared, and the entire process is shared to the staff, whether the staff is present in the meeting or not, but all the results or analysis, we can say, for such type of error is shared with the staff, so that such type of errors, they do not happen again in near future. Next one, please. This is very important. We gather regular patient feedback as per the quantum of work we are getting at our hospital, both for the OPD patients and inpatients. We are taking the feedback, and that feedback analysis is done, and we identify the potential gaps in the diagnostic process, and it helps us to make the necessary improvements in the future. Next one, please. We continuously monitor the diagnostic accuracy and patient outcomes. The data is used to identify trends and areas for the improvement of diagnostic process, and this is basically done by the review of all the medical records We have not yet introduced at our hospital the electronic medical record or electronic hospital record system, but very recently we'll be going for that, and certainly then this particular outcome will be improved in our hospital. Next one, please. In future plan, we have planned for the advanced diagnostic technologies like artificial intelligence, etc. I just discussed about the EHR of EMR, which can analyze the complex data and identify the patterns that will be missed by the human providers. So thank you. And I would like
Thank
to
you
have
so
the
much, Dr. Sharath, for sharing your case study with us. I would like to open the floor to our panelists here, if you would like to share your viewpoints.
Dr.
Ms.
Sharath, first of
Nadira,
all,
Dr.
compliments on
Yeah.
the systematic way that you are learning and preventing errors. I particularly appreciated 2 points you made. Number one is the collaborative effort between multi-specialties, and the second is the follow-up that you're doing and teaching it back to the people who are concerned with the diagnosis process, because it's only learning that will help it. I have one
Yes.
small question. If you have a
Yes.
specialty, and you mentioned second opinion, that's my third compliment, because this is where we are struggling to tell our patients to please take a second opinion for maybe serious illnesses or maybe serious treatments or difficult treatments, and people hesitate. So suppose somebody has a dental problem or an eye problem, how would you involve somebody who's not related with that specialty into the process? And when would you involve it? And who will decide? 3 questions. When, who, and how?
Ma'am, suppose if any other specialty patient is having eye problem or dental problem, and we want to seek the opinion for that particular patient, we frankly give the option to the patient that this is the panel of the doctors who is
No, that does not answer my question. No. That's exactly where we fail.
consultant to.
That's exactly where we fail. My perception. The specialists are so myopic. They're excellent in their field, but they become myopic and they do not think of something else. I'll give a real example. Somebody with dental problems had an oncology problem, but it never reached the oncologist because the dentistry was busy with dentistry and more dentistry and more dentistry. That's my question. I think I lost you. Shall I repeat that? Did my question
Yes,
get
ma'am,
lost?
I am able to hear you now. There is
Okay.
a lot of interruption in internet, so
I'm
we are
sorry,
having
I'm
very
sorry.
heavy rains today.
Yeah, I'm sorry. No, my question was very, very specific. And this is where diagnosis also goes wrong. Not that the doctors did not do the right job. They did it, but they did not go beyond their right job. And that is why I asked, who decides when to call somebody completely unrelated with the basic problem, and and when is it decided, at what stage? Because if it's too late, if it's a gastric problem, or was it an oncology problem in the example that I gave? Was it a dentistry problem or was it a cancer problem? That's all I wanted to park. So getting people involved from other departments is as important as getting second opinions from the same specialties. That's all. Thank you.
That is a very good question from your end, but unfortunately, Dr. Sharath's network is not very good today.
Yes.
And
yes.
he is freezed for me at the moment. Maybe we can get back to
Later.
that question, ma'am.
Yes, yes. Thank you.
We'll discuss with him later. Thank you so much. If anybody would like to say something from the panel, most welcome. All right, thank you so much. Moving on to our next case study from Dr. S. Kumar Velu. He's the medical director, Dr. Ramesh Cardiac and Multispeciality Hospital. And I would like to open the floor to Dr. Kumar Velu. Sir, over to you.
I think you can go forward, Rema, because I think he is not here. Maybe we have lost him. So on the
Yeah,
network, please,
sure,
you can
sure.
move forward with the third one, please.
Yeah, thank you. So our last case study, I would like to move to Ms. Nidhi Raj Verma, who is joined here. She is the compliance officer, Nova IVF Fertility, and she's also our assessor in ART accreditation program. So welcome to you, ma'am. Over to you.
Thank you, Rema. Thanks a lot. Thanks, first of all, to one and all that I am given this opportunity to speak over here. I'm feeling privileged to share my case here. So I'll just share the screen. Is it visible? Is it visible to everyone?
Yes, ma'am.
Yes, ma'am.
Yes, ma'am. Yes.
It is.
Okay. So actually, I was given the topic that improving diagnosis for patient safety in fertility care. So before starting the entire, discussion, I just wanted to place, as we all know, fertility is not a emergency care. It is an elective care. When I say elective care, that means somewhere we, as a fertility provider, we have to be much more conscious in terms of taking care of the patient, because we receive the patient not with the physical wound, not with any fracture or any illness which can be seen, which is tangible. We receive the patient with intangible pain, which we can only understand while talking, discussing, and counseling with the patient. So here, this is the main thing which I wanted to place it across. And then after that, I'll discuss about whatever. The overview is basically the importance of accurate diagnosis in fertility treatment. This is what my first thing which I'm going to cover. Then second is, what is the challenges when we are treating the patient in infertility? Then the third is, what all are the steps which is being taken while addressing the fertility issue in a holistic way. Then the next is impact of diagnostic accuracy on patient safety and treatment outcome. So these all are the topics which we are going to cover today. So importance of accurate diagnosis is, first thing is, what is the way? So as Dr. Indu and Dr. Nadira has shared, that talking to the patient and listening to the patient is most important thing. So when we take history, we have to listen to the patient very consciously and very, with very mindfulness. We have to listen to them so that we can really understand what all history they have gone through in these many years when they have come for the treatment for the fertility. So that we can plan the personalized treatment as per their history, personal or maybe family history, depending upon their all those history correlating with each other. Then we have, because if we will take the history in a personalized way and we will do the treatment in a systematic manner as it is expected from the fertility aspect, we can improve the success rate of the treatment. Then avoiding unnecessary treatment. If we will take the history in a systematic manner and we will capture all those details which is required to address and to understand, then we will be able to avoid unnecessary treatment. Like, for example, if the patient has already done AMH a month back, so we are not supposed to repeat those AMH. If you feel that AMH report is valid or E2 report is valid, then you will not repeat that treatment once again, or you will not ask the patient to go ahead and get the treatment done once again. Then if we will correlate everything very nicely and we will have a case discussion every day, we will be able to detect the problem in a very systematic and in an early stage, even for the complex issues. Then optimizing the time of pregnancy. Definitely the patient who visit to us, they have high expectation because they feel like in a single goal, we are going to have a baby. So how come we can, meet their expectation unless and until we will discuss and we will understand their complete clinical understanding and psychological understanding about the treatment, whatever they are going for, we can optimize it and we can achieve the pregnancy of the patient, for the patient. And then, as I said, this treatment is an elective treatment. So here because the patient goes for a lot of psychological and I'll say emotional turmoil they go through, because fertility is still, infertility is, maybe the WHO has defined infertility as a disease, but still it is a taboo in the world, in the society. People doesn't talk about it very openly. Hence, they have a lot of emotional, they go through a lot of emotional turmoil inside the heart, and they don't even discuss these challenges even with their partners. So here we have to take care of everything in terms of emotional and psychological well-being for that particular patient. Now, because we are talking about all these things, we have to talk about the challenges what we face as a fertility clinic in the while treating the patient. So first thing is definitely fertility treatment is not a one person's treatment. It is a combination of male and female. The challenges can be more maybe towards the female side or maybe male side, or maybe this can be a combined factor for a treating consultant to deal with, right? So then the next thing is variability in patient condition and responses to treatment. Means when we treat any patient, we don't know which kind of response is going to come with this treatment with such person, because everybody has their own response. They respond to the medicine differently, every person. So that is also a challenge. Then third is limited patient knowledge and high expectation from the fertility treatment, as I mentioned earlier as well. So the patient and the society has very limited knowledge about the fertility topic itself. And then they expect the moment we will enter into the clinic, we will get the baby. They feel is as if this is a ready-made thing, we can do it. So hence the education plays a major role here to reduce such challenges. Then balancing advanced technology with patient comfort and safety means because we receive the patient physically fit, maybe emotionally not very fit. So in such scenario, we have to be very, very careful when we are advising any treatment or any diagnostic services that should not be uncomfortable and unsafe for the patient. We have to be very, very conscious when we are choosing any diagnostic alternative for the patient. So these all are the challenges which we face as a fertility clinic, right? And then steps what we take in our center, in our clinic. So starting with the diagnostic accuracy, so personalized diagnostic pathways on history and risk factor. So what do we do when a patient arrives to the center, reaches to the center? From that moment onwards, it takes close to 2.5 hours time for us to evaluate the complete history of the patient, starting from their clinical history, their family history, all these things. And we have very set pattern of evaluating all those things so that nobody should misses out anything, whatever is important to derive what is going wrong in the terms of fertility. Then we also take intervention of artificial intelligence in choosing the right gamete, in choosing the right embryo before implantation of the embryo. So this is all things we are doing. Then collaboration with the leading diagnostic lab for reliable result. So as many of the speakers, they have spoken about the reliable result, and which is on the basis of that, the 70% people are making their diagnosis. So definitely, unless and until you have a reliable lab who are good in giving the accurate result, you won't be able to succeed in getting the right diagnosis, right? Then patient education on the diagnostic process and consent taking. This is again a very, very important thing, because our fertility this domain is led by a act which is called ART Act. Assisted Reproductive Technology Act, and in that act and otherwise also it is being guided that we have to take consent for each and every procedure whatever we are planning to take the patient for. So in that consent, basically it is mentioned what all are the pros and cons of this this particular procedure, which is being explained and educated. The education is going to be given to the patient before the diagnosis. So this is what makes a major role in making the diagnostic accuracy in place. Then transparent communication. This is, as many of the people said, that communication is not only, talking to somebody and not listening to the person. So that is why in our system, we have multiple counselors starting from the registration of the patient till the send off of the patient from the center. We have multiple touch point where we interact with the patient. So for the treatment plan, the entire clinical team discuss the treatment plan, and then the clinical coordinator or maybe the assistant doctor, they discuss about the procedure. They do the procedure counseling, whatever is doctor advice after the consultation. And then the financial, whatever the finances which is going to be involved in this treatment, that also going to be discussed very transparently. Then what all are the diagnostic results and outcome which is going to be, which a patient can expect after this diagnosis or treatment, that is also very transparently discussed with the patient. So these all are the places where we touch upon to the patient, and that is the reason we take 2.5 hours time in completing one patient's entire life cycle in the center for a day when he or she is visiting the center for the first time. Then, as I said, psychological understanding. This is the most important thing. And in NOVA, we have a complete standalone department for the psychology. So we have chief psychological counselor at head office who discuss all the different type of cases with the counselors at the center on weekly basis, so that rest of the team can educate themselves, and if at all they are encountering such kind of cases in their clinic further, they can actually address it, right? So we evaluate the psychological aspect of the patient in a very detailed manner, and we communicate with the patient on very regular basis. It's not that the patient has come today and we have discussed everything in length today, and then after we are not discussing anything. So in every 15 days, 7 days, 15 days, and 21 days time, we touch upon to the patients who are crucial, and then accordingly on the basis of their severity of the psychological status, we discuss, we talk to them, we try and understand, we help them, we handhold them during this entire treatment of the fertility. And it's not that once the beta HCG of the patient is positive, we leave them aside. No, we follow them up until the live birth is recorded and done. So we keep them into the into the loop of the follow-up mechanism until the live birth delivery, so that they will be feeling like, yes, wherever I have taken the treatment, the people are they are taking care of us completely in this entire cycle. So to meet all these things, what is the most important thing is protocol. So the protocol is basically a standardized protocol for initial assessment of the patient. When the patient is visiting the center, we have a standard protocol to assess the patient. Then we have regular training and workshop for all the staff, starting from the clinician till the front desk executive. Everybody is trained for the different protocols. Then we do regular review on patient protocols till the outcome. And we have monthly review meeting on the clinical aspect, on the psychological aspect, on the embryological aspect, so that we can understand everything in a very clear manner. And then we can actually we can somewhere summarize, and we can make some sort of further progressive protocol for the patients in future. So this is what is about the steps taken by the NOVA. Then impact on patient outcome. When we do all these things, definitely we are enhancing the precision of infertility diagnosis, which results in more personalized and effective treatment, of course, after doing all these things. And then accurate diagnosis contributes to higher success rate in IVF and other fertility treatments. Then early and accurate diagnosis combined with counseling help reduce the patient stress and anxiety. Then improved patient satisfaction leading to higher B2C referral channel, because if the patient is satisfied and happy, they will go and say that, yes, this is the center where the people take care of us very nicely. You should also go and take the treatment there. And we also run a program where where the successful patient who has come beta HCG positive, they discuss with their entire journey with other persons who are advised for the IVF, so that they can relate and they can understand that, yes, this is the way we have to go for the journey. They discuss all their challenges. None of our staff be there. It is only patients they discuss, so that they can discuss openly about everything. So this is all about my presentation. Thanks, everyone. In case people have any question, please come across.
Thank you so much, ma'am, for your
Thank you,
wonderful
Rema.
presentation. Anyone from the panelists, I leave it to you for your views over the presentation given by Ms. Liddy.
I can only compliment you on the huge area of psychological zone that you have made, because I think this is a very emotional decision even before they come to you, and a very painful process. Whatever I've seen of people getting into this, procedure. So I'm very, very happy about that. Just one small question. You mentioned that you take consent forms, right? You take consents. How many people really understand the consent form? Because this consent form business goes everywhere, and we are in a hurry to just sign off without really understanding the benefits or the alternatives.
I will tell you. So we have psychological counselors in the center, right? So, and also the clinical coordinator, they are also called assistant doctor. You can call them assistant doctor. So when we go for any treatment, so before that, we do procedure counseling. In that procedure counseling, we explain the entire consent, what pros and cons of this procedure going ahead, and they discuss about the safety and outcome of the procedure. So we discuss in detail. That is the reason we take minimum 2.5 hours with one patient. And we give a very customized thing. If patients want to understand in Hindi, we explain them in Hindi. If they want to understand in Kannada, or maybe in Punjabi. So we call such people, so that, because we have everywhere different kind of people, right? They might not understand English, but they can understand their regional language. So we look for somebody who can explain them. So we always arrange a good detailed consent understanding meeting with the patient, not only with the patient, when I'm saying patient, I'm talking about the female. So male and female both are there. We explain pros and cons of the consent in detail to them, and then only we take the signature. We don't take it beforehand. We never take it beforehand.
Thank you, Nidhi, because this is a problem in even other areas.
Yeah.
So thank you for
in
explaining.
multi-speciality, definitely, I was also having the same sort of challenges. We generally don't explain too much in detail about the consents, but here we have really very good practice. We discuss and detail out every line item in the consent. Yeah.
And I hope the family is involved in this, not just
Yes, of course. If the couple wants that the family should be involved, then only be involved. If they feel like we wanted to be, we want to do it secretly, then we don't involve.
Thank you. Thank you. All the best.
Yeah. Thank you. Thanks, Dr. Nadira.
Thank you so much, ma'am. It was a very good presentation from your side. So moving on to our last presenter for today, Dr. Kumar Velu. He is joined now. So, sir, over to you.
My slide visible? Is my presentation slide visible?
Sir, we are not able to hear you.
Am I audible now?
Yes, sir.
Am I audible?
Yes, sir.
Yeah. Good afternoon, everyone. Sorry for not being in time because my videos are running a bit heavy. Now, the topic given to me was a case study, and what I have chosen is thrombolysis in ischemic stroke when they come within the golden window. World Patient Safety Day, improving diagnosis for patient safety is the theme, and get it right and make it safe is our. I'll start with a small case with it. An 82 years lady, non-hypertensive and diabetic, came with acute onset slurred speech, facial deviation to left side with the right-sided weakness. This occurred at around 1300 hours. She was evacuated to our hospital at 1500 hours because she was evaluated in the ER and post-stroke was announced. I'll just share the video with the consent of the patient. You can see the first slide. As you can observe on the face, the right half of the face is not moving, while the left half is slightly normal. You see the next slide. You ask the patient to lift both hands up. And you can see that the right hand is not able to hold the position and falls down. Right? This was done after giving the injection in the emergency. Now you can see that she is following commands carefully. Now we'll see the hand. She is able to hold the hand very well. Now, coming to international patient safety goals, it revolves around 6 parameters as the expert panelists and the viewers are aware of. We identify the patient correctly with an effective communication thereafter. Safe medication, surgical safety, prevent hospital-acquired infections, and prevent patient harm from false inception. Now, first IPSG, as it applies to our patient, is hospital ID becomes one of the ID which has to be administered, what is known as a unique medical record, which should be already the patient has an armband, which should be seen and identified accordingly. And the patient is called out to call the family name, because in Andhra Pradesh, we'll have plenty of people with the same name, namely like Srinivas Rao, Krishna Rao, Subba Reddy, and things like that. Only the village name differs. So we always insist on the village name before we go ahead with the further management of the patient. Now, why should we do the ID? Is basically to ensure the right patient gets the correct medicine and the treatment there. Now comes to IPSG2, namely the effective communication. We need to improve communication amongst the staff members, which we'll do by informing them post-stroke has been announced, the patient is within the window, and the patient has to be given thrombolytic agent. This is what is communicated, and the members are trained appropriately at regular intervals as to what each member of the team should do. Like, depending on the conscious level, one will do the interventions like a right tube insertion and a Foley's catheter for urination, and others will continue with the taking the consent after they take a audio-video consultation with the patient's attendants. When we explain to them at length what is the procedure that we intend to do, what is the patient's diagnosis, what are the positive benefits, and what are the negative impact, what we call as side effects. So we insist on this and we allow the patient to take a detailed discussion and their doubts are clear there. But you must always understand stroke is a real emergency and need to be attended with the least possible delay. So we clearly tell them 30% of your patient is likely to improve with this drug. However, there are side effects, namely anaphylaxis and bleeding, which is a major complication which can occur with a thrombolytic agent. This was told to them, and they are given time to consult their family members if they need one. However, insisting on the fact that every minute delay will lead to death of around 19 million euros. This is communicated to them in clear terms. So what I say is communication should have clarity, should be competent, delivered by a competent and a confident person, and it should be complete, explaining the benefits and risks. And last but not the least, the management takes on the last part of it, which is also counsel. Coming to the next, IPSG 3, namely safety of high alert medication. The medication in question here is intravenous thrombolytic agent, which can be either 2 drugs we have in India approved by the government. And this, before a procedure, medicines are labeled like you have an IV medication loaded in a syringe. So we insist that they should be loaded effectively by the people, especially when they are completed and some medicine is left in the syringe. That should be done. Then if you have got somewhere we are keeping them elsewhere like cups and basins should be done. And it should be done in the area where medicines and supplies are set up. We should always take extra care with patients who take medicines to thin their blood like aspirin and clopidogrel. And we should record and pass along correct information about a patient's medications when there is a transfer of patients from one area of the hospital to another area, for which we need to find out from the attendants, the previous medication, compare these medicines with the new medicines that we intend to give to the patient. For example, RTPA, pump blocker, antiplatelet agents, statins, and others. Coming to the safe injection practices, we insist on aseptic technique and precautions to prevent contamination of sterile injection equipment. We insist that we do not administer medications from a syringe to multiple patients, even if the needle or the cannula of the syringe is changed. Needles, cannulas, syringes are not to be reused for another patient, not to access a medication or solution that might be used for a subsequent patient. Fluid infusion and IV administration sets are always on patient per patient only and not to be disposed appropriately, the appropriate container. Consider a syringe or needle cannula contaminated once it has been used on a particular patient. We should always have the single dose vials rather than going for multi-dose vials where we administer multiple patients as and when. Coming to IPSG 4, this is applicable only when our patient has got a large vessel obstruction and has to be subjected to mechanical thrombectomy, where they undergo a procedure, catheterization plan. So where they follow the surgical safety list, the timeout is done appropriately for mechanical thrombectomy or an aspiration. Now, the next IPSG 5 is to prevent hospital-acquired infection. Use the hand cleaning guidelines from the Centers for Disease Control and from the World Health Organization. You have to set goals for improved hand cleaning by monitoring the thing which our HIC team does it on a routine basis, and wherever there is a deficiency, the individuals are counseled appropriately. We have care bundles for each of the hospital-acquired infections, namely ventilator-associated urinary tract infection and skin bed sores. And we always encourage our staff to document without fear that somebody will find, why are you documenting this? Don't do it, because we encourage them to have a free hand for doing document. Coming to the last, IPSG 6, prevent patient from fall. That's why we have the catchy slogan displayed along the patient, behind the patient, catch the falling star. Side rail should be in place. The functioning call-bell system should be ensured. Early and timely response from the healthcare worker as and when there is an emergency. Proper assistance to stroke victims. Effective solo screen should be done in the method it is done. We follow the FES protocol and prevent bed sores. And if it occurs, take appropriate measures to treat the same. Now coming to access. So in the hospital, the access from outside the healthcare facility for the patient, visitor, staff shall be smooth, unhindered, and facilitated. Provisions for disabled patients such as wheelchairs, ramps, railings, lighting, etc. shall be provided as per standard guidelines and which are being provided. Access within the healthcare facility is for internal pathways like for doing an MR or a CT should be smooth, unhindered, and facilitated. and which is being done and monitored. Emergencies, movement and evacuation should be done and ensure care continuum during the process of fire and disaster drill are done at every regular intervals, and each and every individual hospital is trained to do what he or she is supposed to do in case of an emergency, both internal as well as external. To conclude, patient safety is supreme. Adhere to international patient safety goals at every step. Take consent properly. Administer thrombolytics with least delay. And ladies and gentlemen, time is brain. So that our patient should not have such a gloomy outlook, and they should have a beautiful roadmap ahead with appropriate intervention from us. Thank you. I finished my presentation.
Thank you so much, sir. Wonderful example put out by you, sir. I would like to open the floor to our panelists if they would like to share their views. Dr. Somesh.
I think fantastic. Dr. Kumar is, as usual, he's a veteran, he understands, and we could only learn from him. I think fantastic it is, and I'm sure he knows it more than us. And I have seen patients with strokes. I know what difficulty it is to identify and timely. You know, that golden hour is very critical. In the country, still, we find a lot of patients not even identifying. And sorry to say, even the good clinicians, you know, in the tier 2, tier 3, or maybe at a good tier 1 also, are not able to diagnose at the right time. If these are followed, probably we'll pick it up at the right time and can send it to the right center at the right time. So thank you for this enlightening, you know, insight to stroke. Thank you so much, sir.
I'll give a small narration if the panel permits me.
Yes, please.
What exactly is that? We used to do what we call as a public awareness programs at regular intervals, where I used to target school-going children and the college students. You must be wondering, why should I address these people? It so happened that one patient was picked up by the patient's daughter, a 16-year-old college-going girl, identified that the father had stroke. And the patient, I insist on fast. And one more thing I always tell them is, do this sign. Ask your patient to stand up and do namaste. If a patient of stroke can do this, you can be rest assured the patient does not have stroke. Right? So that is what I tell them. That is the Indian version of fast. That's what I do. Okay. And this girl picked up the father, brought the patient to our hospital, and we could thrombolyze. And fortunately for the patient and for us, the patient went back home. Awesome. That's the most important thing. And of course, as Somesh has correctly brought out, public education and awareness is mandatory. I always deliver talks to my own colleagues, MBBS doctors. With due regards, I always even educate the so-called compounders, or what they call as the first responders in a village or a small place, because they are the ones who are going to see them. I tell them how to identify stroke, and I tell them kindly push them to the nearest hospital. I always tell them, don't bother about Ramesh Hospital. Tell them to any hospital where they can be thrombolyzed, so that we can save one life. And in the bargain, if he's a breadwinner, we'll save one family.
Thank you so much, sir. Thank you for this. Thank you.
Compliments to you, Dr. Kumar. The way you put all the 6 IPSGs into one case study. That was a very nice thing to learn from you. I thought they were always separate, but you combined them all. And please do help us to spread awareness on stroke, saving the golden hour. Frankly, I did not understand how you save the golden hour, because you have to take consents and explanations and this medicine and that medicine. That question is still hanging in the air. But even the hour before I reach you is more critical than the hour after I reach the hospital. So we are working on that area, and it would be wonderful if you could teach us to teach other people what to do.
I'll do that. And what I do when the patient comes to me, the counseling starts on the MR console. It's not in this room. Like as soon as, and I have got a limited scan protocol for acute stroke within the week. It takes just 10 minutes. People must be wondering, why MR? But just 10 minutes, the study is completed and the counseling starts 5 minutes from there. Within 5 minutes of the initial scans, I call the attendants to the console, show them on the console that this is the problem. Your father has developed left-sided weakness, what we call in Telugu is Pakshvadam Uchindincham, so that they understand that. And I show them this is the lesion and this lesion has not become permanent. So it is likely to benefit. Thereafter, I tell them, let's go to the room for counseling because I want the subsequent talk under audio video counseling because all our talks are centrally monitored and entered into continuous audio video recording. And I tell the patients also, whatever you want to do, we will be able to answer you and you can have access to what I have told you and what you have asked me the subsequent day. Is what it
two bottlenecks there, Dr. Two. There are two bottlenecks there. Number one is the knowledge. There is a knowledge skill or the limitation of knowledge with the person who brings the patient and the knowledge of the person who receives the patient in the hospital. I think only knowledge and awareness can eliminate these two bottlenecks. And that's why we need.
Our ER is geared up. The moment a patient comes in, we have a code stroke announced. All the team members, like my residents, me, will be there in the ER within 5 minutes.
That's because you're ASTA, but everybody is not an ASTA.
Everyone can be.
So we need to make the patients some ASTAs.
No need for any doctor can do it. It's not that ASTA is doing it. Only thing, yes, we have time frame set and we stick to it. And if you don't, and there every month we have a meeting where we analyze all those tips and take them.
Wonderful, wonderful. Thank you for that.
Dr. Nadira ma'am, that time my connection was lost. You were telling something regarding the referrals of the patient.
Yes.
For the second opinion in the case of dental or ophthalmology. I
Yes.
just missed it. I would humbly request you to please repeat that.
My question was, you mentioned about collaborative approach to
Yes.
consultancies. You also mentioned about second opinions, which I compliment you on that. But my question was, suppose somebody has a dental problem and your specialist refers it to for second opinion to another dental specialist. But suppose it was cancer. Same thing, suppose it was an eye problem and actually it was onco problem. When do you get the oncologist on board? Who decides when it is decided and how is it decided? Because otherwise you miss the boat again. Because the dentist will look at dentistry and more dentistry and more dentistry. Same thing, a gastroenterologist will look at gastro and gastro and gastro. Where does oncology get into the picture?
Yes.
That was my question. And then the game is lost anyway. Just food for thought.
Professor Nadira, I think in international scenario, this is Somesh, I think in the international scenario, there are something called medical specialists who are, I'm forgetting the exact name of it. They are the people who receive and be part of any treatment. So for example, a patient goes to dentist, that doctor is on and it's a specialist. It's not a resident doctor on the floor. So they, along with it, they're like a physicians, right? So they're the people who take the history holistically beyond just a bottleneck where you're just seeing that specialty of dental or eye, right? They are the people who ideally should pick up. But unfortunately, at least in Indian healthcare, I've seen it. It's very dependent on the primary consultant.
Yes, it is.
So, till when we break that bottleneck in some hospitals and make sure that patient is treated as a whole, I think we'll keep having these issues. And I've seen this in good hospitals of, I will not name it, but I think your cardiac centers as a single specialty institute, I was part of those. You come with a gastroenterology problem in that hospital, they'll pick up some changes in ECG and suddenly patient is coming back to me because I was heading, saying that, yeah, I have come in this hospital for my gastroenterology problem and I'm being treated as, first you get this done and that done of ECG and other changes. So basically, yes, you're right. There are so much of bottleneck when we work as a single specialty, super specialty.
Yeah, blinkers on, yes. Absolutely.
Yeah, blinkers on. So
since we are on the QA, thank you, doctor. I appreciate that, but everybody doesn't think like that. And since we are on the QAI forum, and this is a request to QAI, that in case, what do you do with ambulatory services? What do you do with people who are outside the hospitals, private clinics, private doctors, neighboring doctors? They are not associated with any large hospital. They're not even accountable to anybody. They are not they may be responsible, but they're not accountable. And I'm talking from real experience here. So can you add an accreditation norm or whatever you want to call that, so that in case something goes wrong repeatedly, if it recurs repeatedly, if it intensifies again and again, they must an absolute must as part of the accreditation, refer it to a higher hospital or a multi-specialty hospital, or as Dr. Somesh, what word did you use? Global expert or something like that. I want to catch that word again, please. And they must refer that, and it should be part of the norms that before you certify that, so that you get it into a system. I've seen the value of accreditation. I mean, tremendous. But I think we need to catch this because we are beyond the net. The fish is outside the net. How do you catch that fish? That's the point. Thank you.
Thank you, ma'am. That is a wonderful suggestion. And we'll certainly add that this particular standard in our accreditation for hospitals. Yeah, sure. Thanks for the suggestion.
Ankita, that's homework for you.
Yes, sir. Yes, ma'am. Of course.
Thank you, everybody. Sorry, I put questions which were difficult, but we face these difficulties, and I think that's my job.
But sure, these questions make the sessions more interactive as well.
And with,
so going forward,
with all due respect to everybody here.
Thank you so much. So going forward, towards the end of our session, I would be doing the last, and for last but not the least, Dr. Somesh Mittal. He will be, he is presently working as a CEO in ART Fertility Clinics. Previously worked as Director Operations at Shears India Healthcare Management Limited. He was a part in healthcare vertical and MD and CEO for a private equity company as well. He was a Zonal Director of Fortis Escorts Institute. Have played multiple roles for many hospitals for the last 25 years. So we would like to listen from him on the closing remarks valedictory. And so I would request you, Dr. Somesh Mittal, to please do the closing remarks for this webinar and conclude the webinar for us. Thank you.
Thank you, Ankita, for this. I think good afternoon to all the distinguished guests, panelists, and all the friends and colleagues. I think it was a wonderful learning session for me. I really learned a lot today. First of all, I would like to thank WHO for bringing this crucial issue back on stage of saying the role of accurate diagnosis in safeguarding patient safety. Second is definitely QAI for setting up this webinar to discuss among ourselves as senior leaders about improving diagnosis for patient safety, getting it right, and make it safe. I think fantastic topic. But I was just going through and listening to all the speakers which were there and the ideas. And yes, we were talking a lot on how the diagnosis, how the communication, technical errors and others. But I think senior people like Dr. Kumar and maybe Professor Nadira and all will agree that somewhere during the time of these technology and advancements in AI, we are losing that important bit, which is the most critical. At least when I studied my MBBS and post-graduation in oncology, our professors used to always say that 95% of your things are history taking. I think today what is happening, I feel the new generation, yes, they have with them all these AI-based and all diagnostic things which are available. But we used to be told that 90%, 95% of your diagnosis is made with a proper history. Somewhere down the line, I think new generation is losing that discussion, talking to patient. And what is happening in the end is we are not making an accurate diagnosis because many times you pick up, there is a fracture, something in the spine which is going on, but the patient is having an issue with the tailbone fracture, for example, right? And everyone is talking about spine issues which are there for many years, and that's leading to it. That's because the history has not been taken properly. So I strongly urge that somewhere we should also make it a habit to create a proper diagnosis, a good history to be taken. And I'm happy that Nidhi was talking quite a lot on history taking and others. I think that is the most critical to my mind. Yes, of course, today's generation with MRIs, with CT scans, with AI solutions, all other things are available that those should augment our diagnosis. So that's one thing which I just wanted to add upon. Getting it right, I think that's the way to go about it. Making it safe, I think with all these diagnostic tools which are available, it will make it definitely safe for us. So I think we are in a right space. If we can conduct this, if all the organizations have a proper team for patient safety and quality, where we should invest more money, we should keep a fund separate, because that's going to take a long positive way in improving the patient outcomes and diagnosis and safety and security of those. I think with that, I will just urge to all the people who are available here, let's all commit to being champions in taking this forward. It's just a beginning. I think long way to go for all of us. as an India with 1.4 billion population and varied ethnicity, varied level of from rural areas, from tier 2, tier 3, tier 1, there's a stark difference which is there. So let's all continue this journey, and QI, as Professor Nadra was saying, you are the ones who can take it down to those no one's hospitals which are there. They are just accredited. I think that is a place where a lot of gaps are still there, and I think we can lead it with your support there. So thank you, everyone. Thank you so much for this enlightening session. Thank you.
And I just one point. Thank you, Dr. Somesh. I just wanted to tell the entire group that yes, we have working, as the foundation has worked on a white paper recently, which says exactly what Dr. Somesh is saying: sharing, listening, teaching patients, and through the entire care pathway, we have designed touch points where medical people can interact with patients, where patients can interact with medical people. And the one goal, reducing errors, increasing patient safety, and not missing any chance to take feedback, which is integral to learning. And this was released just 2 days ago. It is actionable points on several stages, right from before the first appointment, taking the first appointment, navigation, OPD, choosing the right doctor, post-treatment, discharge processes, pre and post-surgical, as well as hand hygiene and home care. And we're calling this, we just put the link on the chat. Please read it, use it. It's a simple thing, role of the HCPs, role of the patients, and how together we can interact to improve patient safety. And we're promoting it widely. We cannot do it without you. We urge you, we request you to populate it, to use it, and to send us your feedbacks. Good luck to all of us in this patient safety journey.
If you may, just last comment. Yeah, thing is, as Somesh has correctly pointed out, in our training, I have a DMD program in neurology. I tell my students, I don't see images. I see the patient first. I make my impression. Then I do the imaging to confirm what I have gained from history and practice. And in neurology, 75% of the diagnosis is history alone. Examination is to confirm what are the historical facts are, and investigations to probably be channelized to stroke. That's what I do. But yes, in stroke, when they come to acute window, the questions are limited. We have a scale internationally followed, what we call as National Institute of Health Stroke Scale, where we just quickly find out what's a deficit and go ahead, do the imaging, and we do a subsequent screening of these patients at a later. Thank you.
What we have published. So it's very simple, but very useful. And we're beginning with errors by patients, but the role of both of us. So this is just a quick glance. We won't take much time, but this is worth looking at. And this is for all care settings, primary, secondary, tertiary, including clinics, including outside, and most importantly, patients before they come to you and patients after they go back home. Thank you. Thanks, Varsha.
Thank you, ma'am. Thank you, everyone. Thank you, Dr. Somesh. That was a very apt closing remark, and it serves the purpose of the webinar. QI mission is always is the knowledge sharing, that the experts who are coming from the different industries, they're sharing their experiences, and it's a lot of learning from all of you. So this webinar is always going to be successful in future as well. We don't see that timings are always going forward. We understand that, and we really apologize for that. But next time, I'm sure that we will take care of all these things. So going forward, the last thing is that we have conducted a kind of article submissions, and we have received many articles which were very related to the topic and what the hospitals were exactly doing. And they have done a lot of things to prevent the safety culture. So I would like to take the names in this forum, and if they are present here, so please come on the video so that we can congratulate you. So I would be sharing this one slide. I hope you all can see, right? So the third person who we have received a lot, and the third person who has done a very good job is Ms. Shalini Sharma. She's in the Head Quality and Patient Safety in Fortis Hospital, Mulund. Thank you so much. Your article was very interesting interesting, and you have shown us the pathway that how your hospital is taking care of the patient safety in improving diagnostic errors. The second thing is Dr. Surbhi Pandey, Professor, Pathology Department, Shri Ram Murthy Samarak Institute of Medical Sciences and Hospital, Bareilly. So thank you, ma'am. You have done a very wonderful job. We liked your article and it was very extensive. And the first one who has received, and I want to congratulate her, that Dr. Sandhya Rangarajan, consultant microbiologist, Kaveri Hospital, Chennai. So all of you, congratulations. We will be sharing your certifications for those purpose that you have shared the best things in what is going in your hospitals. Thank you so much for that. If I can see the faces who are present here for the who has been awarded. Okay, if they're not here, okay, we can go forward. So the last vote of thanks. So on behalf of the QA team, I would like to extend my deepest gratitude to all of you for being a part of World Patient Safety Day 2024. This event would not have been possible without the collective efforts of everyone who is involved here. Our sincere thanks to our esteemed panel of speakers, Ms. Nadira, Dr. Zisam, Dr. Himshika, Dr. Indu, Professor Suttan, Dr. Sameer, and I would also like to thank Dr. Sharad, Dr. S. Kumar Velu, and Ms. Nidhi Verma for presenting such enlightening case studies and offering a real-world perspective on patient safety. A special thanks goes to my moderators, my team, Rehma and Sakshi, for seamlessly guiding us through today's program. So finally, I would like to extend our gratitude to all the attendees, the participants. Without you, nothing would have been possible. Healthcare professionals who have taken the time to join us today. Your commitment to improving patient safety is inspiring, and we hope that this discussion has sparkled some ideas and actions into you. And we conclude today's program. Let us carry the message of getting it right, making it safe, forward in all that what we do. Together, we can continue working towards safer and more reliable healthcare for all. Thank you, and I wish you all safe and productive journey. I will request 1 minute that my colleague Sakshi would take one picture. So I would request all of you to please come on 1 minute on camera so that we can take the picture. Sakshi, please do the needful. I would request all of you to please share your smiling faces, please. Sakshi, you can take all the screens, please.
Yes. Smile, everyone. Got it. Thank you so much.
Thank you, everyone. Thank you for the wonderful participation. We hope to see you soon with other webinars and with other programs. Follow us on LinkedIn and get more ideas what we are going and what we are planning. And thank you, ma'am. Thank you, everyone who are here. It was a very enlightening session. Thank you so much, everyone.
Thank you.
Thanks.
Thank you.
Thanks, everyone.
Thank you.